Saya dengarkan pembaca the next session will be panel discussion. Since we have so much sensitive for time. Our presenter from abroad, they have a strict schedule. We need to keep their schedule so that next session will be moderated by Professor Mazgabo and Dr. Zacho. So based on their sessions, they will moderate both this session.
Good afternoon and welcome to this session of the Joint International Annual Research Conference organized by Amara Public Health Institute. So today's panel brings together four critical and interconnected areas of public health that include the foundational importance of early childhood development in the Amara region, strengthening emergency health system by integrating psychosocial support, and the remarkable progress in remaining challenging eliminating trachoma, and how to implement implementation science can translate evidence into scalable crisis responsive health solutions. So these are the public health importance topic for today's panel discussion. So the panelists are Professor Nasaret Fantaun, Dr. Bikisani Yerdau, who will join us virtually, Mohammed Fayiso, and Dr. Iheno Alamu also will join us virtually. These topics reflect both challenges and the resilience of our region, where health systems are navigating conflict, displacement, disease burden, and resource limitation. Yet they also highlight the opportunity for innovation, community engagement, and evidence-based program. So saying this, I will introduce the first presenter or panelist, Professor Nasaret Fantaun, who will speak on early childhood development in the Amara region. His presentation will unpack the current state of early childhood development in the region and highlight opportunities for strengthening multi-sectoral intervention, providing an essential foundation for the discussion that follow. Though it's very difficult to introduce within a short period of time, I will try to say something about Professor Nasaret. He's one of the few young professors in the country, and he's corporate director for research affairs at Bardar University, and a professor of nutrition in the School of Public Health, College of Medicine and Health Science at the same university. He holds a dual PhD in applied biological science, that is food and nutrition, from Ghent University, Belgium, and human nutrition from Juma University, alongside an MPH and BSc in health promotion in Juma University. He's also leading public health nutrition, and he has made significant contribution to nutrition research, governance, and capacity building in Ethiopia. He has authored more than 120 publications with more than 40,000 citations, and his work covers emergency nutrition assessment, maternal and child nutrition, food system, and multi-sectoral nutrition governance. He has led and collaborated on major projects funded by the UNICEF, USAID, WHO, and others. And his notable contribution include rapid nutrition assessment and the smart survey on the impact of conflict on nutrition and health in the Amara region. And he has also played key roles in nutrition sensitive and nutrition specific programs, food system research, and regional nutrition leadership, including supporting the establishment of the Amara Regional Food and Nutrition Council. So, welcome Professor Nzana. So you have 30 minutes for presentation. The floor is yours.
Good afternoon. Thank you very much for inviting to present an regional agenda. We officially declared this finding for the last Sunday with the presence of regional council and the regional responsibility. So now this is the research forum. We discussed to just show what the main finding of the childhood. It was conducted with the different collaborators as regional flagship project. This is typically an implementation research. With this finding, there are a lot of proposed intervention at regional level. So my presentation topic is unlocking potential. We have children with unlocking potential. So the state of early child development in another national regional state. Here are the team. We have different teams. The University side and the African Center for Early Childhood side. So we have this presentation outline. I will briefly present what you mean by early child development. This is a recent agenda of global agenda and national. So we will focus on these areas when we talk about early child development. We are dealing about physical development. And then we are thinking about cognitive development, language development, and that's social-emotional development. How our children seems like with these parameters. You know, when we invest on early childhood development, you know, the kids of the first year of almost all brain development, health, and learning and behavior established. When we talk about the kids of intervening on early, especially 0 to 6 years, the investment is cost effective. Within $1 investment on early child development, an average of $16 return. And then when we talk about the case of risk in the case of early child development, currently more than 250 million are children suffering from this development risk. When you talk about brain development, you see in the case of the first 6 years, almost 90% of the human brain is developed. So we need to invest on 0 to 6, that's why we are focusing on early child development. You can see here where the brain development, the milestones take off. You can classify the brain development 0 to 12, 1 year, 1 to 2 years, 2 to 3 years, 3 to 4 years, 4 to 6. What type of brain development at this stage of and different categories of years? So that's why we are investing on early childhood as national agenda and the regional agenda now. These are the most sensitive time period in the case of early child development. You can see the different domains as stage of 1 to 3 years, 3 to 4 years, you can see the development. And then after 4.5 years, they're declining. So we have to target our intervention. And then we can see if I'm not properly treating and managing this age, what be the outcome? Can see the outcome of study, the indicator of brain. These are a different point. Those, that's the group of connections, neural connections. Can't think about mobile phone. We have busy. Agriculture is at 9 million. Doesn't mean interaction does anyone. So we need to think about the brain development at the age of 0 to 6 years. So the situation, this is an early and recent agenda, so we get the limited evidence, even national and regional level. And then we need to document and then design an intervention. That's why we have conducted this study. Our objectives, there are different objectives for this presentation. Assessing the child development outcomes. We are classifying to 3 to 6, and then particularly school children under 4 to 6. And then at 6, 8, what are the ratings of children? Then nutritional status, finally what are the determinants, and then the key practice, and finally how the structure, the policy landscape of the regional level. But in the case of matrix section, we conduct an analysis, 5 clusters, Bahadar CDA, in rural areas, conducted 24 cabanas, Gondar City and nearby 24 cabanas, Desi City and nearby, that's 15 cabanas, the rural conducts 7 rural and 7 urban, 14 cabanas, Chemistry, 5 rural and 3 urban, total 8, and total 8 cabanas in Namala region. We have a different study population. The first of household survey, quantitative components, study participants under 3 with private caregivers, we classify age under 3 to 6 with different standard tool, sample size 03, almost 1,639, 0326, 927, and 5,073. We use a different tool, Canadian Dihila, caregivers reported an early development instrument, and identify international development and early learning assessment tool. These are the domains for assessing 0 to 3, 6 to 6, 0 to 6, 0 to 5, and total. We use this standard tool. And then we have very respective study populations. And then the case of community, we conduct qualitative, we did FGD with different individuals, and then we conduct FGD, and then secondary was sectors. We have 4 zones and regional 5 clusters, implemental sectors, institution and school and household and rural. And then the next one is the facility-based assessment, quantitative, pre-primary. We selected 10 pre-primary school. We are using different instruments and including the directors, responsible teachers. We use MEDA and then IDELA. And then the case of facility, we use daycare assessment, playground and facility assessment, it's a comprehensive assessment. And then we also conduct qualitative for facility. We did the interview with different individuals, and then also finally we did policy landscape analysis. Just to picture and understand early child and another region. So with this scientific procedure, we come up with very important finding. Now, the case of demography, we know this variable is important for child development. So we see 80% of rural and 20% of urban proportion for the case of sampling. Primary caregivers in mother and Namala region, maternal education 4.5, 4.9 is primary completed, and 28 is secondary. Paternal education, you can see, because it's a very important case of early child development. And then boys and girls ratio almost is similar. In the case of women's index, almost 40% of the children are from low income. And then one of the important issues in the case of early childhood is the learning materials. So when you talk about the learning material, you can see the learning material into educational materials to learning materials. When you see in America, almost 51% of the household has no any educational material for children. When you talk about the case of working proportion, you can see 66% of households within low income has no educational materials. And we talk about stimulation materials, almost 10% have none compared to the educational group, 40.41% has more than 4 stimulating materials. You can see in different terms of work and are different. When it comes to family engagement, one of the very important components for early child development, you can see overall engagement in the case of mother and fathers. Relatively, fathers compared to others study is just almost 45% of mothers engaged for with children in the case of learning. What are the learning activities? Reading, you can see singing, taking child out, and playing is a very important element. Early child development. Then emotional support, and emotional support, and from the mother, the most important, and children and fathers are also compared. Related to other study, similar to that in Addis Ababa, Oromia, Sidama, Central Ethiopia, and Territory. So we are comparing with that finding. And learning support, you can be teaching learn new things, teaching letters, and then the key takeaway message. Almost all issue of early child development is die on mothers. So with this understanding, we are thinking about family engagement. These are the very important family engagement activities, and then their benefit on developmental milestone. You can see if a father or mother see those children, what type of developmental milestone develop and it benefit. You can see these are the key finding, the key basic finding from our study. So we have to think about what type of activities are important in the case of developmental activity. You can see tell the story, then what are the neurons that develop with tell individual. We need to play with children. What are the developmental domains that are improving? And then what are the neurons that are developing? In the case of family, we need to talk about what are the developmental domains, and then what are the neurons developed. So you need to think about that point when you teach and when you just play with our children. This is our assignment, because we have children all. So, with these activities, what are developmental milestones? Here, under 3, we can see our developmental score from 0 to 5 and 14. We have a range of 50, average plus or minus 10. The range is 40 to 60. So we can see our children. So when compared to that, with that range, our children just at stage of moderate. And then we have some if the case of 0 to 5 and a critical stage. We need to think about these are our developmental score under 3 years children. What are the negative predictors for this? Urban children, lower index, stunted children, do not get growth monitoring and promotion, lack of access to learning stimulation material. One is a very important predictor for negatively affecting the children milestones. When you see the case of outcomes, that's the score. This one is the outcome. So, in this case, based on this finding, our children less than 3 off track is 22%. When compared to the international, which is 5%, it is 4 times more than the global cutoff rate. With this, there were different studies. 97, Impure, Oromia, 90.9, Drillion 90.2, Sidama 90.5. So we need to think, we have to avert this issue. We can see differences in terms of urban and rural, can see lower universities. Here, we teach the importance of nutritional child development. It shows that 65% of child off-track contribute as stunting. So we compare to the non-stunting, 60% of the contribution of development off-track is stunting. You can see this one. When it comes to others positives, any 6 are positive predictors. Then the really matter as score 43%, positive parenting, 60% contribution for child development outcomes. And then when you see that in the next parameter 6 years, you can see the rates, the score, total score is 44.4, which is going with that category. Our children's moderate attainment, but especially in the case of literacy, the critical issues from children 3 to 6. When we see the case of disaggregating, we see the case of genders, residence, wealth index, within different domain of children, you can see the very critical issues literacy. The other just as moderate level. And then, what are the developmental score for children from the school level? We have different domains, community level and the school level. So, primary school level, we have totals 969, and then the lowest is literacy score from both community and the school level. So, we need to stick on a very important literacy point. These are the factors as community level. We have these factors. Children within the school, these factors. So we need to tackle within the factors. And then we have also housing, where we try to see the school readiness at age 6 is the transition from pre-primary to primary school. How much the children are ready with the community level? Mastering is the golden standard issues. Only 54.2% of the children are ready for primary school. The other is just 42 is emerging. There are issues to consider. The rest of 3.7 is off track. That's struggling. You can see that in the pre-primary school, 57, only 57 are ready for primary school. These are the mastering definition, emerging and struggling. We talk about mastering, emerging and struggling. We talk about this one. With this definition, we have 54% of children that are ready for primary school. These are the factors, residency, pre-primary, wage index, homeland, values, very critical factor for school readiness. So we need to target based on these predictors. When we talk about health and nutrition, we assess this one. You can see that there are very important predictors. Dietary diversity, 65% of children and 60% of mothers are poor dietary diversity. In the case of minimum acceptable diet, is 16 for children, which need a very urgent intervention. Immunization and growth monitoring, which is almost 56 and 60. Very important age of child development. When you talk about nutrition, you can see we have a different developmental score under 3 to 6. When you see the nutritional status from under 3 is 39. which is 60%, 65% of the contribution of off-track is standard. In the case of under 5, you can see 77, 37. You can also see not only under nutrition, over nutrition coming. In the case of under 3, it's not 18% of children within overweight. Under 3. Under 5 is 60. So we have a double burden, under nutrition and over nutrition. So we need to just talk about the possible intervention. So these are early child development facility. We assess also daycare. Almost all daycare at quality is low, undertrained, and with government support. And then only 40% of health systems integrate early child development. 2 in 5 playground lack a basic instrument, basic infrastructure for early child development. 4 to 9 parents are practicing only positive attitude. So we need to just teach. Policy landscape. We need also to look at policy landscape. There are roadmap, strategy framework, but these are the limitations. We assess this one: weak funding, intersectoral collaboration, limited workforce, for community awareness for pre-primary school, positive parenting, and disabled inclusive and neglected, and lack of system integration as policy landscape. With this understanding, we are concluding almost 4 times the global outlay of time. Developmental strongly linked with residency, worthy nutrition space starting chronic malnutrition, home stimulation, and growth monitoring. At community level, we have a different samples as community and school. At community level, the developmental domains that moderate level, the critical variable for that is learning materials and adult engagement was very important critical for developmental attainment. But age 6, only 50% of children are fully ready for school. And malnutrition are very critical developmental issues, and then lowering the child development. Self-integration, a very challenging one, fragmented. Conclusion, recommendation, we have different recommendations. Short-term recommendation, and a long-term recommendation. In short-term recommendation, we need to improve access to learning materials, expand equitable distribution of primary education service, integrated ECD within routine health service. We know health service focus on physical dimensions, growth monitoring and dealing about physical one, not the whole comprehensive. Strengthening intercultural collaboration and clarifying institutional roles in the city, increase the public finance for the city, provide training for workforce. We start this one, and then addressing child malnutrition. Long term, we need a very commitment and then a very large investment. I acknowledge big win, you know, ይህኛው እንደ አንዳንድ በአማርኛ ብናገሩ ደስ ይለኛል። እነዚህ ሰዎች ያቋቋሙት የዓለም ባለሀብቶች ናቸው ተሰብስበው ለህብረተሰቡ ምን እናድርግ ነው። ስለዚህ የእኛ ባለሀብቶች ምን ያስባሉ ማሰብ ያስፈልገናል። እነዚህ ባለሀብቶች ተሰብስበው ነው ስራ የሚያስበው። አፍሪካ በሙሉ ፎከስ አድርገው እየሰሩ ያለው አፍሪካ ሴንተር ፎር ኤርሊ ቻይልድ ዴቨሎፕመንት Amara Regional State for the last 1 year with the different competing interests. ይሄኛው አጀንዳችን ብለው በዙም እየገባ በየ24 ሰዓት በየዙም እየተከታተሉ እየደረሰ እያሉ በተለይ የማህበራዊ ክላስተር አስተባባሪ ዶክተር ሙሉነሽ እጅግ እናመሰግናለን። የመንግስቱ የክልሉ መንግስት የኢሲዲ ኮኦርዲኔተርስ ከላይ ከታች እያለ በዚያ ክራይስ ውስጥ እንድንሰበስብ ተለይ ያደረገ እጅግ ምስጋና ያስፈልጋል። ኢምፕሊመንት ሴክተሮች አሉ። ጤና፣ ትምህርት፣ ህፃናት እና እናቶች ህፃናት፣ ሌላኛው ደግሞ አርባሌ ነው። እነዚህ ኢምፕሊመንት ሴክተሮች ከላይ ከታች ሲሰሩ የነበሩ ይህ ባለቤት ትልቁን የክልል አጀንዳ ሲሰጠው አጀንዳ ነው ብሎ እዚህ ድረስ ነው። ከዚያ በኋላ እንዲሁም ኤርሊ ቻይልድመንት ሴንተር እናቋቁማለን ተብሎ ትንሽ ፖሊሲ የተሰጠ ዳታቤዝ ታሪሽ አድርጎ ትራኬሽን ከዚህ በኋላ ነው። ቤዝ ላይ አሰስመንት ነው ያልኳቸው ኢምፕሊሜንቴሽን ሪሰርች ነው። ፎር ዘ ካሚንግ 20-30 years ሊቀጥል ይችላል ፕሮጀክቱ። ያንን ስታብሊሽ ትራክ የሚደረግበት መካኒዝም እንፈጥራለን የሚል ለእሱ ለማኔጅመንቱ በጣም ፖዘቲቭ ሰፖርት ማመስገን እፈልጋለሁ። ኮኦርዲኔተር፣ ዳታ ኮሌክተር፣ ዊዛውት ዳታ ኮሌክተር የዳታ ዛሬ እዚያ ይመጣል። ሱፐርቫይዘርስ ዊዝ ክራይስ በዚህ ተቆሰ በዚህ ነው ሲሰሩ የነበረ ቱ ቢ ኦነስት ሲሰራ ስለነበረ ዳታ ኮሌክተርስ እናመስገን እፈልጋለሁ። ፋይናሊ መረጃ የሰጡ ስተዲ ፓርቲሲፓንትስ በጣም እናመሰግናለን። ይህ ይመስላል ያለው ከብዙ በፊት
Thank you, Prof. Nasir, for your insightful, thoughtful presentation and for finishing in time actually. So let's give a big hand again. He told us about early childhood development and why we should invest in early childhood development and factors that affect early childhood development that include individual level factors, cognitive level factors, health and nutrition, even the facilities. My initial point would be, is childhood, early childhood development problem reversible? አንድ ነገር ትዝ ብሎኝ ነው። አንድ ሰው የአሜሪካ ሀገር ሲሄድ የእኛን ሀገር ሰው ኤርሊ ነው አይደንቲፋይ ማድረገው ብሎ ሲዋራ እኔ ስላልሄድኩ አላየኋቸውም እና በቀላሉ ይለያሉ ይባላል። ለዛ ሲሄዱ በምንድን ነው የሚለዩት? ኢትዮጵያ ውስጥ ሄደው አንዳንድ ጓደኞቼ ለምሳሌ ዛሬ ዓመት አይቻቸው ውጭ ሲሄዱ በጣም ለውጥ ያመጣሉ። ቦርጫቸው አካባቢ ነው። ሌላው ሉዝ ፓርት ስላልሆነ መጀመሪያ ከቀነጨረ በጣም አስቸጋሪ ነው። ስለዚህ ዚስ ኢዝ ሴንሲቲቭ ፔሪድ የሚለውን ነገር በደንብ ማየት አለብን። and the importance of fatherhood, especially in our context, is also important. So saying this, I will introduce the second presenter who will join us virtually, that is Dr. Bikisany Yirdao, who will speak on healing amid chaos, integrating health and psychosocial support into emergency health system. His presentation will address how we can build emergency systems that respond not only to physical health needs but also to the psychosocial trauma that crisis leave behind. To say something about Dr. Bikisany Asrat, he is an assistant professor at the London School of Hygiene and Tropical Medicine, where he leads research, teaching, and capacity strengthening initiative focused on global mental health. His work centers on the design, implementation, and evaluation of mental health and psychosocial support intervention in humanitarian context, including during infectious disease outbreak. Dr. Bikisany's research examines scalable and contextually grounded mental health interventions that address population level needs. He collaborates closely with international public health agencies, including the World Health Organization, UNICEF, Africa CDC, which supports the development of technical guidance, policy framework, and implementation strategies to strengthen the integration of mental health in emergency preparedness and response system. Dr. Dixon is also an assistant professor, faculty of epidemiology and population health, London School of Hygiene and Tropical Medicine, and rapid support team, UK Health Security Agency. So these are a few words about Dr. Dixon. We will have, if he joins us virtually, can you hear us? Yeah. So you will have 20 minutes for presentation. So the floor is yours, Dr. Dixon.
አመሰግናለሁ ፕሮፍ መዝገቡ አመሰግናለሁ ሁላችሁንም በዚህ መድረክ ስለጋበዛችሁኝ ይሄንን ፕላትፎርም አላቀውም ተጠቅሜ አላቀውም እና እዛ ሸር ብታደርጉልኝ ስላይዱን በጣም ደስ ይለኛል ኦርጋናይዘርስ ያረጋችሁልኝ ነው ወይስ ልጀምር እዚሁ? Okay. Thank you so much, colleagues and my mentors. I can see my mentors just there in the audience and some colleagues as well. So today I'm presenting mental health and psychosocial support and how this program can address or incorporate it into emergency response. Next slide. So 20 minutes is a bit short to cover all the slides, but just there are slides outlines here. You can read them later after my presentation. And next slide, please. All right. So why mental health is fundamentally important during emergencies? I think every one of us are just living in a difficult situation, and that's understandable that difficult situations lead to mental health issues. For example, emergencies, conflicts, and infectious disease outbreaks, when they happen, they just bring threat to life and safety, as well as loss of life and grievance and social disruption, as well, importantly, disruption of the already existing health services. So all these are linked to mental health and psychosocial challenges. Next slide. This is about COVID and the COVID pandemic and its impact on mental well-being and mental health. We can recall how many sleepless nights we spent during the COVID pandemic when we look at the number of people dying from COVID and related health issues during the COVID pandemic time. And that actually led to an increase in number of cases, for example, for depression and anxiety, and 100 million new cases of people with mental health issues were reported in 2020 alone. So this is a big number actually linked with emergencies. Next slide. So looking at looking at the global evidence, in regular times, 1 in 8 people are expected to have mental health issues, whereas during conflict and war, this number is getting low. Around 1 in 5 people just get, mental health issues. But the WHO actually reports that all people who are affected by emergencies and humanitarian crises develop mental health issues, especially psychological distress, for at least a brief time, even though they recover over time. Having this burden during emergencies, governments allocate only 2% of the health expenditure for mental health, which shows a huge gap in addressing this demanding health public health issue. The next slide. So how can we address this mental health gap as a fundamental question to address? MHPSS appears to be very important at this point to fill at least the basic mental health gaps through providing basic mental health services by trained people and also access essential medications. Next slide. What's mental and psychosocial support is a fundamental point, I think, to just give you a definition. It is a local or outside support that aims to protect or promote psychosocial well-being and prevent or treat mental health disorders. So it encompasses both prevention and treatment scopes. So it's a bit complex in its scope. The complexity starts that just from earlier presentation, for example, Prof. Anna just presentation and outlined how nutrition and food matters in our cognitive development and of course to mental health as well. So mental health and psychosocial well-being is just linked with food, nutrition, shelter, security issues, economic issues, employment, education. All these dimensions contribute to mental health outcomes. So prevention and promotion and accessing all these basic necessities can improve mental well-being and of course will just promote mental health. This is the pillar, the MHPSS pillar, when just the first layer is all about ensuring basic services are in place for emergency affected people when they displaced from their place and from their local areas and their livelihood is damaged, where their security is in threat. So this ensuring all these things in place are a fundamental contribution to promote just mental health. Okay, the second layer as well, a very keen program that focuses on addressing mental health issues through communities and families, whereas the later layer, like layer 3 and 4, need more focused intervention for those clinically impaired mental health or people with mental health issues. Okay, next slide. So this is the global structure where health and other sectors collaborate in each other during humanitarian response. These are actually UN agencies, mostly work on food, shelter, health, logistics, and education, and childcare protection. So all, I would say most of these agencies or sectors are expected to deliver mental health and psychosocial support. But just until recently, MHPSS has been left for health sector, where it has been very important in other sectors too. Next slide. All right. So how can we incorporate or include MHPSS across each sectors is very important question. Of course, has been a debate for several years. In some sectors, they say it should be a cross-cutting program that can be included in each program, whereas Africa CDC and some other agencies just take it as a pillar and standalone pillar. Anyway, but just in any way, there needs to be a coordination point where it monitors MHPSS programs across sectors and evaluates their effectiveness. Next, please. Thank you. So this is a framework, an incident management, in the incident management system that our mental health team here just developed and shared with UNICEF and WHO. This paper, this can be accessible, but just is not published in a peer-reviewed journal so far. Just we are working to publish it, but it's available there online. So you cannot read and understand. The texts are very small. So just the red color shows the leadership architecture, where it has core pillars under it in the incident management system. And then there are blue colors, and these blue colors are sub-pillars. And the green color shows how MHPSS can be involved or incorporated across these pillars. So this program, this framework helps to make a decision to involve or incorporate MHPSS programs across each pillar during outbreak response, during emergency response. I hope APHI to have a similar structure in office. Thank you. The next slide, please. Well, just I have recommendations here. Actually, yeah, just keep going to the next slide. So these recommendations, I draw these recommendations from our study in Uganda. We just took this guidance, the MHPSS minimum service package, where WHO and UNICEF believe that this is a minimum service that can be provided during emergency response. It includes around 14 program activities, but when we just evaluate the program in Uganda, we find out just around eight of them. Well, 5 primary program activities are fundamental, important. So it needs adaptation to the different contexts. So my recommendations are based on from the study finding in Uganda. So the first one is there is huge gap in coordinating MHPSS with and in across sectors. So it needs a practical and functional coordination. For example, in the APHI may need to delegate MHPSS coordinator who can coordinate all MHPSS activities just implemented by various sectors. They can use the technical working group, MHPSS technical working group. They can work collaboratively with them to disseminate the guidelines, protocols, as well as to understand the context or the spread of the service across the region or the country, or affect population. And these MHPSS experts, of course, implementers, need to adhere the public health measures imposed, for example, infection prevention and control measures imposed by the government and other restrictions. Next. Other one is conduct rapid MHPSS needs during emergencies. Just you don't need to spend more energy, more resource in conducting in-depth assessment. However, a rapid MHPSS need assessment is fundamentally important to understand what resources are available, to what extent the needs are, in which groups of people these MHPSS services should be accessed. and of course, to understand the gaps in terms of resource, capacity, and logistics. Next slide. And then contextualize the available resources. MHPSS materials guidelines is very important. For example, you may have guidelines already developed for a COVID pandemic. So adapting those guidelines for like for other disease outbreaks, for other conflicts or humanitarian emergencies is fundamentally important. So adaptation actually minimizes the cost of expenditure to buy or just develop new materials. Next slide. And including MHPSS across risk communication and community engagement is very, very important. The first problem, for example, when new emergencies happen, misinformation, disinformation, rumors, all these contribute to mental health issues. And this has to be managed in a centralized way through governed media outlets where the validity of the information should be checked and disseminated to all sectors of affected people and a trusted media. And this actually promotes mental well-being of affected people. Okay, next slide. Strengthening the existing services, strengthening the integration of MHPSS across existing health services and primary health care facilities and community health programs is very important. Just quickly, just train primary health workers, community health workers to deliver basic psychosocial support, mental health support is fundamental. As well, this is another area to work. The other one is care for frontline responders and volunteers. This is really important because frontline workers responders are very important, especially they just lead and to just save life. However, their life is at risk as well. There is huge stress and workload, and of course, a risk of having or acquiring a disease from the response itself as well. There is a risk of being, killed or just a risk of being targeted during response. So they operate under a very stressful and pressurized working environment. They need mental support. They need some sort of psychological and social engagement. They need to have these safe spaces to ventilate their emotions and to work together and to have a very positive impact in the response. There are PFA methods, psychological first aid procedures that can be taken for frontline workers and responders. The last one is monitoring, evaluation, and learning. Well, this is a fundamental point just for decision making to evaluate the success of programs ongoing, or to understand the gaps and the limitations in the provision of services. These are I think my slides. This is the last slide I have. I'm very pleased to have this presentation on this stage. Thank you so much. I'm very willing to just take some questions if there are. Thank you.
Thank you, Dr. Bikisai, again for your powerful and insightful presentation, and you have also finished in time. Let's give him a big hand again. Yeah, saying this, yeah, in your presentation, just I may not get another chance. You said 1 in 8 people live in mental disorder or mental problem, and 1 in 5 in conflict settings. But previous presentation, the prevalence is high. So here, the prevalence is almost 20 to 12%. So my question may be, is the data for Ethiopia or globally? So you can respond later. So this is also a nice presentation. So the third presenter will be introduced by Dr. Gizacho, Dr. Garacho. Welcome.
Can I respond to this question first, or just is it later?
You can.
All right. Yeah. Well, just these the data I just presented from global evidence, but to avoid confusion, my point of statistics there was about clinical mental health conditions at global level. Clinical and probable mental health conditions have different interpretation. So mostly in research in Ethiopia or in just the wider world, we use screening tools that show probable depression, probable anxiety, probable schizophrenia. But the clinically diagnosed mental health issues are much lower than that. So this is about just my presentation indicated only specific to clinically diagnosed cases. Thank you.
Okay, thank you very much. Good afternoon again. It's a great pleasure and honor to meet you here today at this historic event, especially during these challenging times. Your Excellencies, distinguished guests, ladies and gentlemen, I will request you to give me a minute to say something about the Joint International Annual Research Conference, because I will not get another opportunity to say something about this. As most of you know, in the earlier times, Professor Almayo is also with us here. There were many annual regional research conferences conducted by Regional Health Bureau, and after the establishment of APHI, also there were annual research conferences which were regional. In 2022, after Belai became the DJ of APHI, we were planning to conduct the annual research conference, the regional annual research conference. We discussed a lot, and the issue was raised by Belai. Belai, myself, and our research team, we thoroughly discussed about the issue to change the name from regional to international, from institutional to joint. The reason for this were many, but three most important issues that we discussed and reached in consensus were: we do research and the student globally for the wider community. That was one critical point. The second point was science has no border. And the third point was research is the team's effect, it's not an individual's effect. So after thorough discussion, and focusing on these three principles, we agreed in 2022 to start the first joint international conference. And we conducted the first joint international conference with Baghdad University. And that conference was productive and colorful. We learned a lot from the joint international conference. We gained a lot from that conference. And we have got opportunities to reach the international community virtually as well as in person at that time. And then we continued the second, we conducted the third, and now we are here to participate the fourth joint annual international conference with the Forum for Higher Education Institutions. I think this is a proud to be for FHI as well as Baghdad University and for the Forum of Higher Education Institution, because we are escalating, we are widening the participants, our collaborators, and also we are minimizing resource and maximizing our efforts. Thank you very much for allowing me to say this much about the joint annual international conference, and now it's my pleasure to introduce our next panel presenter by saying some few points about him. His name is Mohammed Biso, and the short biography of Mohammed is he has Masters of Public Health at Juma University and Bachelors of Science in Public Health at Hausa University. He served at Dilla University as a lecturer, assistant professor, vice director for research, postgraduate and continuing education, and also he served as the chairperson for institutional review board at Dilla University. He also served at the Ethiopian Medical Association as a senior research officer and managing editor of the Ethiopian Medical Journal, and he currently working at the Carter Center as an epidemiologist, consultant, and Mohammed has authored and co-authored more than 30 peer-reviewed research articles. And today, Mohammed will be presenting for us elimination of trachoma as a public health problem in the Amhara region, Ethiopia, which is a very important and hot topic currently, and of course this is a neglected disease as we all know, but the Carter Center, from national to local, they are doing lots of things. I think Mohammed will address all what they did, and also he may inform us what they are doing currently and what's their future plan. Please join me to welcome Mohammed. Mohammed, the floor is yours.
Okay, let me say something about my presentation. So, as my moderator is introduced by Mohammed, and I'm really very happy to be here and on this amazing event. Really, I know FHI has a very close area of Carter Center, and we really appreciate how we are working together, and the support is very immense. And based on that, I'm really honored representing my organization in the middle of this interesting event. So,
thank you.
So I present on trachoma research contribution from Amhara region, operational insights, programmatic impacts and feature pathways. As a general mention for this topic, I'll be presenting, I'm not going to present findings or studies all specific studies we have did, but overall, I will show you how we are, what we are doing, how we are doing, and how we are using the evidences for improving the cancer center work on trachoma program. These are the background of my presentation. I will say something about trachoma background, operational researches in Amhara with respect to trachoma, programmatic impacts of those researches, and how we are using the outputs for making decisions, and I will forward some future implications and future pathways where we are going to work together. So, just to start with the trachoma, a lot has said yesterday, particularly by different presenters. So trachoma is the world's leading cause of infectious disease caused by Clambidia trachomatis, and it is a public health problem in around 32 countries in the world, even in some developed countries, as you can see from the map. Its prevalence ranges from South Americans to Australia and mainly in Africa, and it is claimed around 1.9 million blindness over the globe. So, with respect to Amhara, it is historically one of the highly patent area in the world, having almost near to 70% of, or around 66% of trachoma patent in the world, and this is how we should, what we should know where we are, and was being implemented fully starting from 2010, and with this we have as a culture center and with Amhara Regional Bureau and other partners, we have contributed a lot, and as you can see from this map, a lot of districts having high trachoma burden, they now currently transition into more favorable and less than 5%, and around 58 districts have fallen below 5%, and estimated 6.4 million people currently not requiring MDA for trachoma. And so, in addressing these issues, we have covered a lot of, and we have conducted a lot of studies in reshaping the program while we are implementing, particularly the operational researches were done to have some improvements, and even if there are still a lot of challenges that we are facing, and when we compare to what we have, the time we have, it has taken to reach here, there may be some questions on how we are doing, but a lot has been done, and a lot of improvements were also done on improving the program. And particularly, as I said, we have the greatest trachoma burden in Amhara. It created the need to work more, and also an opportunity to do research and operational research that are important to improve the program. And when we say operational research, it is using the research methods systematically to address problems in program operations, find practical and evidence-based solutions, and to improve the program efficiency and effectiveness, or to have sustainable change prevalence surveys that are operational researches that are the core content of the program, where we depend on delivering MDA and other trachoma interventions. We call them TIS, Trachoma Impact Survey, and TSS, Trachoma Surveillance Survey. So based on that, the program determines its direction for how to continue with interventions. In addition to this, we have the enhanced research components intensively, particularly when compared to other areas, intensively included in trachoma elimination program in Amhara region, and we conduct them as a selected, including in the standard surveys or independently to have to share the program implementation. So, particularly the studies we conduct on trachoma infection monitoring, serological markers, and photography-based grading, which are critically important for improvement of the program and to address the emerging issues that even which we may expect in the future. This photo shows the field data collection, where we collect the standard survey for grading, infection surveillance, photo grading, and the serology. So when we say the trachoma standard surveys, as I have said earlier, we conduct TIS, which is the backbone of the program, where we know our direction on how to implement the interventions. It's done 6 to 12 months after the completion of MBA, and it is important for deciding the rounds of MBA for the program. In the trachoma surveillance survey is done 24 months after stopping MBA for those who have achieved the elimination threshold. And that they are important for monitoring and assessing about recurrence and the achievement of or sustainability of the elimination achievements. And the other one is based on this. We also work on leveraging our data use, particularly WASH and trachoma. WASH and trachoma is very issue in trachoma program. So for WASH, there is a WHO standard to collect the WASH coverage, and we collect data for that. And in addition to that, we leverage the evidences to have, or in a way that contribute for the improvement of the program. Particularly, we see key WASH indicators, how they are correlated with CT infection, how they are correlated with the active infection, and some association between the clustering of trachoma based on the WASH coverages, and based on using the data that we use and we conduct such studies. And for example, as you see from this map, we can see how the clustering of trachoma, active trachoma, and the low coverage of water. And the other, as I've said, the previous one is about the standard research, operational research that is recommended by the program, and these are the other ones are the enhanced or additional assessments or research that we conduct to improve, to more improvement of the program, and one of that is trachoma infection monitoring assessment. And initially it was included in 2011, and it's important to measure objectively what the infection looks like in the community and what is actual infection caused with the positive agent of the disease. And we use standardized training that is developed specifically for collecting and for managing the swabs. So until now, we have collected around 80,000 samples of swabs from upper tertiary conjunctiva, and those samples are tested on M2000 PCR, which is available at the APHI, our partner in research. And as you can see from this map, a lot of clusters data has collected, and this 8,000 data has collected all over the Amhara region, and you can see the clusters where we have collected the infection data. And the other one is serological monitoring, which is also very important component of monitoring trachoma, which particularly currently getting a very due attention internationally. So collection of dry blood spots, it was originally started as a new initiative in 2017, and we collaborated with CDC for testing these samples, and all samples that were collected here are sent to Center Approach at Atlanta for analysis of to analyze. So we analyze at and okay. So these samples are originally we analyzed them at CDC Atlanta, and then we have collected, as I said, a lot of serological data here also. We have collected in more than 30 districts. So based on what we have did and with the contribution of the data Carter Center data, now serology is one of the promising monitoring method which is being even about to be implemented with the cutoff thresholds that is being considered now, and we have implemented this a lot, and our contribution in this regard is really very immense, and we have contributed a lot for development of this guidance for using serology as one of the trachoma monitoring, and the contribution from Amhara in this regard is very exceptional with regard to serology. And the other work, operational work, that research work is about photography, particularly these are needed for training and for when the cases are rare to grade and to assess the progress, and Gondar Grading Center was established, and a lot of photos were analyzed after training of the photo graders and also those who take photo. So we have gained a lot of this, and in addition to conducting a research, Carter Center works on enhancing the internal performance of the lab, and a lot of supports are given. For example, M2000 system, which is currently at the FHI, is donated by Abod with support of the Carter Center, and a new transformer to improve the power supply. New building was built by the Carter Center to improve the lab performance, and installed around 4 new 80 freezers to improve the validity of the samples, and install water profile. And in addition to this, Carter Center introduced in-country assessment or examining of the serology data. As I've said earlier, we always send samples to Atlanta for analysis, but currently we have developed a capacity to analyze those samples here with more efficient method, and that was also happened with the support of the Carter Center and the CDC, even before the occurrence of the stopping of CDC for the support of analyzing those samples. So now let me take a few minutes to say what impactful researches and findings that we have did, and specifically in what interests and how those were supported the evidence generation. And particularly in 2021, informal consultation to indicate challenges for trachoma was held in the USA with the support of the Task Force for Global Health, and a new emerging issue about trachoma has raised, particularly about the persistence and the recurrent trachoma, which are new challenges that were happening to trachoma. So to address this, we have done a lot about this area, and those evidences have supported us to improve our program, and particularly to even contribute before this recommendation were put. And after this meeting, a recommendation to have renewed interest in using those complementary assessments that we have doing for the long has come, and all others were using that. And this is particularly how the problem now are raised. Looks like in Amhara, around 95 districts are currently percent districts, and 13 districts are recurrent districts. So, to understand what this recurrent looks like, we have done a lot of research, and as you can see from here, we have seen that around 34% of districts that have achieved the elimination threshold returned back, and we have thought that we need to have some mode of addressing those. And after identifying these problems, we have tried to address those the issue of recurrence. Particularly, we have introduced a wait and watch approach, which contributed and even got acceptance internationally, and which is recognized as one of the maybe important findings. And when we say wait, that means it is not really important to immediately start for every day for every district one who came back, but we need to have some approach to address such problem. So we introduced this and we have waited. And when we say watch, we watch for them for around 2 years and then we do research. So what do this research brought and what we have learned from this? So this study was conducted in two Warada, Matama Warada and Warada town. This is the surveillance survey where those districts have failed the TSS, and for example, the 5.2 for Matama and 5.1 for Warada. So we didn't start every day immediately, and so we again researched or again assessed that in 2021. So after that, the TF became 3.6 in Matama and 2.5 in Warada. So those additional complementary assessments were introduced, and they have paved the way for the decision. So those were not treated again. And it will not. We are following this. We have introduced MBA, which is very costly. With respect to human resource, with respect to financial also. And the other one is understanding of person at home. So just every person is not the same, so we need to understand how they are different. And for example, we have been studying elements, and as you can see from this graph, the blue one is the TF, and it is very high among young age, and the green one is serology. So it shows that serology data it increases with age, so it provides us with additional information on what the need for further work on those districts, just rather than simply keeping on what we are implementing. So to address this, we came up with the child MBA approach, which is also recommended by the concerned partners in this area. And so nationally, this child MBA was practiced in 6 districts and 2 districts from Amhara. So these results show that based on this child MBA coverage, a lot of improvements are resulted, and the infection came from 15 to 4.7 in Wanda and 9.4 to 1.3 in last. So this is the detailed result, and those who have treated both doses, the prevalence of TF is 1.2% among those who have treated both, and among those who have treated not treated at all, around 60%, and those who treated one were 3.5%. So this program has resulted in very interesting improvement. So coming to the final part of my presentation. So what does this results and this work show us? So the operational research in Amhara has immensely contributed not only for the Amhara or in Ethiopia, it contributed a lot for internationally, produced actionable insights, improved intervention design, which brought new initiatives, ensured efficient evidence driven program implementation. This resulted in infection serological monitoring, which is shown to be a promising approach, and complementary indicators have added a very interesting confidence to have how our implementation research work is resulting in what we have achieved. And by having additional one complementary assessment may be important, that it is better to have all them together to have well-informed decision making. So, as the region continues to face persistent economic challenges, sustaining this culture of inquiry and innovation is very important, and we need to require enhanced more additional operational researches, and we need a support from other partners as usual, particularly in scientific input and more research work on this area, support in ethical review and approval of protocols, and consideration for alternative approaches like child MBA and flexibility in implementing this program. Apologies for taking your time, and thank you. This is all. Thank you very much for your insightful presentation, especially on this important program, by the way. I want you to recognize again the Carter Center is the best partner for the country from national to community level. They are supporting everything, working for the community. Please give your hands for them. Thank you very much, Mohammed, and really you addressed the very critical points from your presentation. I catch it. Some very important points. There is a significant reduction in active trachoma prevalence because of your work, and also successfully implemented the SAFE strategy. And you are working strongly with the community and the health extension program too. And also you did survey surveillance and impact assessments, which are very important for program evaluation. And also you did good thing by engaging multi-stakeholder partnerships and the global collaborators also. And also still there are challenges, some hard to reach areas, some backlogs, and also the current WASH program is a contributing factor for this disease, and still the program needs collaboration and maximum effort to eliminate the problem. Thank you very much, and I will proceed to the last but not the least presenter. This presenter is Dr. Heno Alamu, and his short biography is he holds PhD in applied anthropology and specializing medical anthropology. He's minor in public health from Oregon State University, the United States of America, and he served as a visiting scholar at the University of London and Barbara University. He also worked as a U.S. Ambassador Distinguished Scholar in Ethiopia, based at Barbara University and Redwood University. And he has 15 plus years of multidisciplinary research experience in Ethiopia and Kenya. And his research area spans around the medical anthropology, the public health, maternal and child health, the WASH, food and water insecurity, community health, and intercommunal conflicts. So far, he has authored and co-authored over 30 peer-reviewed 30 scientific research articles in peer-reviewed journals, and he has also contributed 2 book chapters. And today, Dr. Heno will deliver a timely and insightful presentation on bridging evidence and practice, which mainly focuses on implementation science for scalable, crisis-responsive health solutions. Dr. Heno, you are around? Can you hear us?
Yes, I can hear you. Can you hear me?
You have 30 minutes, and now the stage is for you. Continue.
Thank you. Thank you. I hope everyone can see me, and can I have my slides here? Okay, I will just start. I hope my slide will be presented here. So thank you for the opportunity to serve as one of the panelists for the 4th Joint Annual International Conference. It's truly an honor to participate in such very important and timely gathering focused on strengthening public health during the time of crisis. So thank you everyone. Today I will be speaking on the panel Bridging Evidence and Practice Implementation Science for Scalable Crisis Responsive Health System. My specific topic for today's talk will be evidence-informed strategies to strengthen early nutrition and feeding support for vulnerable infants. So I will be, first in my discussion, I will be presenting findings from our work in early nutrition and feeding support for small and sick newborns. in saving little life facilities in Amhara. And then I will share key recommendations for strengthening early nutrition, feeding practices in these facilities, and discuss how these strategies can be adopted or even designed from the outset to function effectively in crisis settings. So my aim is to highlight how evidence-based practices can be both scalable and crisis responsive. So to give you a little background about the work that we did, so everyone, we know that small and sick newborns are including low birth weight, very low birth weight, premature and fragile infants who are at higher risk of mortality and morbidity, and this risk can be multiplied in case of crisis because of overstretched health systems, disrupted health systems, and inaccessibility of health systems for several reasons. To come back to the program, the Saving Little Life program, this is an initiative that has been implemented in different hospitals in Ethiopia, which is focusing on strengthening facility-based support for small and sick newborns. So there are different services provided by the Saving Little Life program to help these vulnerable infants. Our focus was looking into the feeding practices within the program. One interesting thing to mention here is the data collected ended before the conflict in Amhara started. So it was 8 months before the conflict started. We completed data collection in July, August, and the conflict, as you know, started in April. So we believe that our studies can be applicable for conflict crisis settings. So I have recommendation for crisis settings as well. We started out our research with the objective of first assessing what kind of early feeding practices are given in SLL facilities for SSN, small and sick newborns. And then we looked into the barriers and facilitators for effective breastfeeding facilities. Then our intention is to inform context-specific, scalable strategies that can strengthen small and sick newborns nutrition. So we started with two objectives, two research questions. The first one is, what feeding practices are available there for small and sick newborns already available? And then what are the factors that hinder or the factors that support feeding small and sick newborn feedings? So we did the study. The study was conducted in 8 public health hospitals in Amhara, primary and general hospitals. It was a qualitative, entirely qualitative facility-based assessment. So we had interviews with mothers with low birth weight and very low birth weight infants. We had interviews with 11 clinicians who are providing support for small and sick newborns in NICU in KMCs. We did participant observation, and then we also tried to look into policies and procedure reviews available there. That we did at the qualitative study, we did both thematic and context analysis. So the findings of our study were published in 2 journals, one International Breastfeeding Journal, the other one in BMJ Open this year. So you can scan the QR codes here and download the whole article because it is an open article, and everything what I will be speaking here now is there except the component that I added for crisis settings. So the findings of the study, I will present the findings of the study in 2 forms. The first one, next slide, please. The first one will be from mother's perspective. So we asked mothers and what their perspective regarding feeding practice for small and sick newborns that they are receiving from in facilities. Mothers said that they report that there is insufficient milk. They are producing insufficient milk. Self-reported insufficient milk was one barrier. The other one is maternal and infant separation, because in cases when we are having infants who are with complications or very low birth weight infants, they will be placed into NICUs separate from the mothers. That had impacts in creating bonding. And we heard that there was limited antenatal care and even postnatal care education focusing on breastfeeding. Some of the barriers were here, and okay, let me use this one. So the other one is we found suboptimal breastfeeding support, which means a support that is provided for mothers below the optimal level that needs to be. So these were some of the what we learned from the mothers, but it's not only just barriers. We look into facilitators, and we found that in facilities, the health workers and the relationship that they have with their partners was very important in helping them improve the breastfeeding and improve nutrition. So the next one is about clinicians. We asked clinicians, health workers, what were the barriers and facilitators for neonatal feeding for vulnerable neonates. So the barriers were multifaceted and categorized into 3 different levels. At the facility level, for example, few training for small and sick newborns feeding, limited space, and absence of or shortage of hand pump for breast pumping. And then whenever it is a necessity to provide formula for newborns, absence of formula, and health workers unfamiliarity with the protocol, the breastfeeding protocol in their hospitals. The other one is maternal and neonatal factors. So neonates inability to suckle for several reasons. Mothers low perceived milk production, and then when mothers are having complications resulting from delivery, this was one barrier. And then parity, mothers who have previous experience in breastfeeding was well compared to first-time mothers. Sociocultural factors, health clinicians told us that some infants after discharge or even born at home, but mostly after discharge, there is still this cultural practice of eulectomy and prelactal feeding that could impact infants' health. They will be readmitted to hospitals, and then that will complicate their breastfeeding, their nutrition. So the notable facilitator was most of the health workers that we have there were women with personal experience of breastfeeding, which was very helpful in supporting other mothers who are having breastfeeding problems. So in conclusion, we found that it is very encouraging to see that most mothers intend to exclusively breastfeed. This is their intention, but the intention was not fulfilled because of the systemic barriers. We found very different quality provided at different facilities, and we recommend that strengthening counseling, reducing separation of mothers and infants, and standardized care, having a protocol that can work, that can uniform standard protocol for low birth weight feeding in hospitals would help. And we think that the findings would inform scalable crisis responding neonatal feeding strategies. So add a recommendation, next slide. Okay, so these are some of the very vital points that we think needs to be taken from this study that can have implications, or also for crisis response settings. I also would like to ask audiences to rate these different recommendations that we have, and include or tell us also additional recommendations you think that would help small and sick newborn feeding. So the first thing that we found is clinical and system capacity improving, like training. It could be on-the-job training or additional training focusing on vulnerable infant feeding, having higher consultations between health workers and mothers, and trying to improve resources. This could be problematic in crisis settings, already stretched resources, but there is a possibility that this can be applicable in crisis settings. The other one is reducing maternal and infant separation. there is a new initiative in Ethiopia, and they're having maternal NICU, where the mothers and the infants will be placed together in the NICUs, which would help creating bond that can increase milk flow. So this can be also problematic in crisis settings, because already there is lack of shortage, and having a facility to have NICU would be some problem, but that would help a lot, because in time of emergency, this is vital. Having the mother next to the infant, the sick infant, is one important thing. The other thing is standardized feeding protocols. We believe that there is a national or regional feeding guideline protocol for all infants and vulnerable infants. This guideline should be available and communicated by providers and the health workers. The other thing that I would like to emphasize is strengthening family and peer support in the time of crisis is one very important thing. I believe that the use of community health workers, which is health extension workers or women development army leaders, if this program is still available, the use of these workers at communities and health extension workers who are also inside the communities would help effective breastfeeding practices for mothers in cases when they may not be able to attend or to come to facilities for several reasons. So these are the different recommendations we have, and I ask the audience to rate these recommendations and how it can be applicable for crisis settings. Next slide, please. Yes, so strategies for conflict-affected settings. Crisis-adapted small and sick newborn feeding protocols. The feeding, which means the one that I explained earlier. So there is a need for rapid assessment and monitoring to understand that what resources are available and what resources are lacking, and then try the best in order to fulfill what's lacking there. And one thing that has been practiced in different places during the time of crisis is the use of mobile phone and telephone to provide counseling and support for mothers. This would be very helpful. For example, we have the health extension workers. Every health extension worker have cell phone. It is possible that some mothers or their husbands or the women development army, the leaders there may have cell phone. So having phone counseling on effective breastfeeding will be helpful. There are also the others. I think you passed it. So the use of community health workers, I also mentioned this. So the next thing is reflections and discussions. So which strategies that we have here can be scalable in crisis settings? If I ask you to rate these recommendations, which one would be the best one to be used? Which one requires most resources? Which could be implemented immediately? And I also would like to hear from you if there are any additional recommendations you would provide that can improve small and sick newborn feeding. So the funding for this research came from Emory Global Health Institute. So I think the next slide. Yes, if you have any questions, feedbacks, implications, interpretations, or critical reflections, you are welcome. Thank you.
Thank you very much, Dr. Hira, for your insightful and informative presentation, and also you finished your presentation in time. So I think it's a very critical area you mentioned. Currently, globally, we have lots of generated evidences, and still the gap between knowledge and real-world practice remains a big challenge and a big problem. So implementation science provides systematic methods to close these gaps by ensuring the effective interventions that can be adopted, adapted, or implemented and sustained in the real-world environment. So
I think your presentation and the issues in the area of implementation science will help us to shift from knowing to doing, and from small pilots to scalable programs, and from reactive to proactive crisis response, and from isolated intervention to sustainable health system change. So thank you very much for delivering the speech for the audience at this difficult time, especially it's in the afternoon, it's in the second day, and everybody is getting tired, but your presentation, I think, gave us some insight. So we will reach to you if we have any concerns later, and now I will call upon Professor Masgobu and the presenters to the stage to take questions and comments. Thank you very much, Dr. Hiro.
Thank you for having me.
Okay, Dr. Dixon is also available if you have any questions or comments. Okay, so if you have any questions or comments, one for each presenter, because of time, I want to limit the number of questions. So, Professor Tabaka, Professor Alamayo, and this side, and then 3, 4, Dr. Hayo. So, let me start from Professor Tabaka.
Thank you very much, all of the presenters. My question goes to Dr. Mixel, if you are hearing me. Dr. Mixel. One question is about integrating mental health and psychosocial support into existing primary health care. Of course, it has been more than a decade since the World Health Organization recommended integrating mental health and psychosocial support plus mental health services into primary health care in order to overcome the shortage of trained mental health professionals, in addition to reduce stigma attached to mental illnesses. However, even the Ministry of Health endorsed this and tried to train generalists to provide mental health services for people with primary or some common mental disorders. However, practically it has been difficult, and we ourselves have conducted research, and it has a lot of barriers to integrate mental health and psychosocial support and mental health services into primary health care. How do you think it would be possible practically to integrate? What should be done to integrate mental health and psychosocial support into primary health care is one question. The other is creating environment for social support. Of course, it is protective against mental illnesses, and many studies show that people with strong social support are less likely to have mental illnesses. These days, our social support is loosening, and there is individualistic lifestyle rather than pluralistic culture. So, how can we practically improve social support? What are the specific strategies for creating social support? Is another question. The third question is establishment of intervention, crisis intervention teams, especially during emergency situations. Many countries have demonstrated effective establishment of crisis intervention team that consists of various professionals, psychiatrists, nurses, psychologists, social workers, even police, integrate to identify, assess distresses or emergency psychiatric conditions and provide treatment in the field, and having a hotspot in order to identify problems related to emergency. But taking our situation, do you think it is recommendable and possible to establish a crisis intervention team to help people with mental illness? Thank you very much.
Thank you very much. So my question goes to Professor Nicholas. First of all, I am happy to see this ECD research. This because what happened to the story. I'm also happy that the first ECD related research with no knowledge was done to implement by EPH some 3 years ago for Addis Ababa. And I'm quite happy and more than happy that that research was related in the presence of many high-level people in Addis Ababa, including the mayor. Then that quickly scaled up to Oromia, Reva, Mala Central, and Sidama. And one big institution was established because of that study. So Africa Childhood Center of Excellence, where I am also serving as the head of one of the technical working groups in that center. So I am quite happy to see this research reaching here this soon. It's very complicated research, I know. It took us 3 months to write the proposal. We had two problems that we faced during our research. One was to get children at age 6, because the national statistics, as you know, it's up to 0 to 5. So how did you reach those children at age 6? We did study at Addis Ababa. We did a census, and we stopped our data collection, and we did a survey of children 0 to 6, and we are completing with $50,000 for about 10 to 15 days. Then we used that as a sampling frame, because initially my thought was that someone was responsible for KG things, data in the education bureau. But when you put it, they don't have that data. The national statistics is 0 to 5, that's also one. So how do you get this age 6 children? And the second question, that was our challenge. How did you put the cutoff for track? And striving and also mastering. Can you consider data pipelines? Because we had a consultant from Pennsylvania University in Harvard, 2 people, they are consulting us. They couldn't make it because they knew research. Finally, we did this cutoff by 25 to 50 days, 70 days or something. And we could also the same.
አመሰግናለሁ። እንደምን ዋላችሁ? Thank you very much for all of the presenters. My concerns and appreciations particularly focused on the first presenter, Professor Muslimat. I appreciate you and your team, especially you are bringing the issue of early childhood development by combining the nutrition and early childhood psychological stimulation together. That is very important. And most of the time, when we deal about children, we forget the issue of early stimulation, particularly on the psychological part. That is my appreciation. Let me go to the questions. I think when we say early childhood or pre-primary or preschool, there are different packages. I think you have included the kindergarten, low class, and daycare, I think. These are the three specific packages of your targets, I think. So, how do you measure the readiness of or the child developmental outcomes of these three particular age brackets? So, can you say something about the measure? That's one. Since when we are talking about children's school readiness for school, there are domains: family readiness, school or preschool readiness, community readiness, and children's readiness themselves itself. So, how do you see these particular areas of readiness that are packaging the issue of children readiness for school? The other is, there are many children who are on the off track in Amara region, and you compare with the other studies like radio, similar region, and like that. The bracket of the conflict issue. Can we compare the context that we have been here in the scenario here with the contexts in another area which are relatively free from such conflicts? So, how do you practice the issue? And the last one is there is a paradox. Most of the time we criticize that preschools are focusing on the literacy and numeracy rather than focusing on the other domains of development like emotional, social, physical, and others. And there are a lot of studies that shows that preschools are highly dominated on literacy and numeracy issues. But your result shows that there is also the gap in literacy. That's a very serious problem that you reported. I think you have anything to say on this paradox. Thank you very much.
Okay, thank you. My question was to the Professor about the Atlas Center. And one of your strategies against trachoma is immediate. As you know, this immediate is an antibiotic massively given to the groups. But these days, drug resistance is a big challenge. So, how can you just address this issue? And from your presentation, I have also seen that there is a tendency of just the trachoma that may again raise at some point. So, do you think this is one challenge? The other from your presentation is I have seen some other issues. There's children with a range of hypotheses, just the growing and this family around our mobile. There's a simple thing that is I'm going to be foreign but the other reforms, so this could be adhered to address this kind. Thank you.
because time is very sensitive issue, and let's stay back to the stage. I think Dr. Heno and Dr. Bisenia are from abroad in the United States of America, so let's give them the chance first to respond, or if they have something to say for 3 minutes each, and then we'll continue the reflection from our presenters. So, Dr. Bisenia, are you around?
Yes, thank you, Dr. Xacha. Yeah, actually, just a small correction. I'm joining from United Kingdom, from London. So yeah, it's not the US. Thank you so much, Prof. Talaka. Yeah, I'm humbled to speak in front of you about mental health, and I know your work, your hard work in the sector for a long time. So the first question around the challenge to integrate mental health interventions or mental health and psychosocial support into primary health care services, which is which is a challenge, of course, in Ethiopia. I've been part of it, and I just I've been part of the WHO MHGAP training to integrate MHGAP in mental health interventions into HIV clinics. It was really tricky and challenging, but the main challenge I would just take it as I could recognize lack of supervision, lack of monitoring and supervision, which wasn't just in place. There was no proper documentation, data tracking system in place, and there was no any reporting mechanism from delegated primary health care workers to take it as a responsibility, as part of their role, to provide mental health and psychosocial services after training. Of course, another challenge is workload. They are expected to do a bit more work in addition to their existing role. So this this task shifting is taken as task dumping. Some people say, oh, it's task dumping, where we are doing others' job. But this mentality has to be changed. To me, how it can be changed, just all these challenges can be addressed through research. We need to find out the real challenge, and we need to address that gap with appropriate capacity building intervention. I would say in clinical settings, primary healthcare workers may not be willing because of stigma, because of other interests, financial issues, but still we need to understand the main problem, and we need to, work, I think, to change that challenge, existing challenge. It takes time, but just over time it can be addressed. And the other thing should be, it shouldn't be the only approach. There are various approaches. For example, integrating the services into community health service, health extension package, and expanding the services through different modalities is something important to consider. The second question is about institutionalizing this or social support in different just pillars during outbreak or emergency response. Of course, it's beyond social support. It's psychosocial support, mental health and psychosocial support. All together are just focusing on prevention of mental health issues, just from fulfilling basic necessities or essential needs of community, like the shelter, hygiene, all this, just food. These are fundamental questions we need to address. And then social support, using existing social support mechanisms. For example, on this, these are not something simple, community assets. We need to build up these associations and including mental health topics in these meetings then people to share ideas to solve problems. For example, common problems, common challenges as a community, as an association or union. How can we address this challenge? Just that problem can be solved just together. For example, security might be a threat, a problem, but as a community, as as people living together, then you can discuss how we can just ensure our security and safety as we are just standing alone. So social support can be there to bring some practical solutions out of for each problems or challenges. The third one is crisis response. Crisis response team and integrating mental health support into these crisis responding teams. There are various teams responding for emergencies, epidemiologists, surveillance team, other educators, IPC, various teams, but logistics as well. At least equipping these people with basic essential mental health psychosocial skills. One, it helps for themselves, for the responders themselves to take care of their safety, their emotions, their mental health issues. And the other is to at least identify or detect people with mental health issues and refer or link to the next level of available care. So that's part of the intervention, identifying and just supporting if possible. As long as you have some basic skills to understand their problem, then if not, just refer or link to the next level of care. So in this modality, I think these crisis intervention groups or these crisis responding teams, after they acquire basic training for 1 week or for 5 days, then they can implement these activities. But still, support supervision is very essential. There are sensitive issues, suicide, homicidality, various risks there. So this also needs attention with proper, standard operating procedures should be followed. So yeah, I would say support supervision has to be the pillar or just the fundamental question, and the reporting mechanism should be fundamental questions that should be put in place. I'm not sure if there is an additional question, just to take on
Thank you very much. Because of time, if there are any issues related with this, we can reach to you either individually or as a team later on. So thank you very much for your response. And Dr. Heno, are you around?
Thank you, but I'm not saying research.
Thank you. Dr. Heno, are you around? So I think there's no question for him also. So it's better to be present.
Thank you again. So I think most of the questions were forwarded to Professor Musanat, so we'll give the chance for Professor Musanat.
Thank you very much for your comment, questions. And, Paradamayo was one of the first person for experience CPCD survey analysis. So we are the third one. After Oromia and Ridawa, we documented the experience. And then we learned a lot of things, how the challenge from Natis, Oromia and Ridawa. We separated on that experience. We discussed even more than 5 months for setting. And then when it comes to assignment for BDU, we said with different disciplines, primary education expert, developmental psychologist, health and nutrition expert, we said and discuss and frame and submit for Africa, ECP, Africa's Center for Early Childhood, and we organized this. And we discuss for 10 days with externals. We are collaborating with Harvard University And then after we back into the Amara region, and then we sit again discuss with different scholars. Even within this field, there are many scholars from UK and Harvard because it's a new concept, developing concept that was a challenge. And we face this challenge, but we learn from your development and artists and Romeo and Director. We are adapt that one. And then in case of saving identified children, from your experience, we are allocating sample size for each age. And then we do with community health workers. And then after the case of off-track, from your research, even still now, the manual is developing. For a series of yearly, a series of manual development issues. After Oromia and Addis Ababa, there is a standard document with cut-off point. We use that one as this code for classification. We do that one based on the classification for under 3. For the sake of 3 to 6, we are using, there is no standard cut-off point. We use a score. For at 6, we are using the different national cut-off. At 6, school readiness for children. We use 25, below 25 is struggling, 25 to 74 is emerging, above 75 is mastering. Based on that, we are classifying based on that. So we are, after that document, there are different initiatives, UNICEF and that developing document. With that referral, we are classifying. Still, the cut-off point is developing. So we are just based on that, we did our assignment. And the case of my friend, you know, this team is just composed of different disciplines, primary education expert, and psychology and health education, and they discuss with Harvard and African Center of Health Development, and then we have a manual using 4 domains, which we are using that one. And then we even after Addis Ababa, the African Center of Health Development, necessary framework which consists of health, nutrition, protection, and development. We are applying that framework. So we are following that standard rather than scholar arguments. We are following that one. In the case of school readiness, you know, there are different domains. We use 4 domains, but there are different readiness. For this study, we are presenting for the only child readiness rather than school readiness, community readiness. We have results on community readiness. We have finding on school readiness, but I present the case of child readiness for preschool, primary school. There are one question, the case of off-track and compare with other regions. We understand that one. When we write application, we are writing under the emergency conditions because for the last 5 years, history is under emergency conditions. Even majority of the children are under 5. So that's even born within emergency context. We are interpreting and designing even policy brief with the purpose of emergency and distributing that policy brief for higher officials.
Thank you, Prof. Nazi, for your response. So we'll give the chance for now.
Thank you. I just have a few questions from Ma'am. And thank you also for raising nice questions. As we have also read, mass registration is one of the safe strategies that is in place for elimination of trachoma, and one of the problems is mass registration, as all of you know, is drug resistance development. So with regard to trachoma MDA, actually there are a lot of studies that are examining this, but there is one study that we have conducted around 5 years back, and it showed that there is no any significant signs of resistance among the chlamydia trachomatis. But there are other studies showing the resistance development for another type of bacteria, and that is there are a lot of studies showing that, which even maybe one of the problems with mass demonstration. But now also we have collected data and sent abroad for doing more on this, and now the samples are in lab being examined for resistance abroad, and I hope that will also bring us some evidence for if there is any drug resistance with respect to mass administration. And with regard to recandescent, this problem is one of the main problems over the lab, actually on this on areas where trachoma is present. So, and with regard to Amhara, even the number of district returning back is slightly better compared to the other regions with performance, but still we need to know more about why the districts are becoming back and why their recurrence is becoming one of the problems, and it needs a lot of work from everyone, particularly other partners also, and we also have a plan to address that, and a lot of studies are now being planned, particularly a longitudinal study to address such issue. And the other one is also as a comment, also to say something about that. Usually in during our training, there is in ethical protocol, we do train our data collector not to take any photo without the consent, and we inform them that we may use some focus for such presentations, but I am not, I cannot say that all this will have really ethical equivalent. I think that was as a comment, and thank you for listening. Thank you.
Thank you. Thank you again, the panelists, for your insightful contribution, and the audience for your thoughtful engagement. As you heard in today's panel discussion, we saw that early child development, care system response, and disease prevention and implementation sciences are interconnected, which are piece of broader health system challenges. So we have to work collaboratively in order to improve the health conditions of the population. Again, in our today's presentation, so that progress can be made, so the region is facing with different challenges that include conflicts and health hazards, and we can also learn the need for what to invest on evidence-based synthesis, and also strengthening cross sector collaboration, and also a need for the innovation to be scalable and sustainable. And finally, the most important thing is that you have to carry the message, the lesson learned from this panel discussion in particular, or in the conference, to our institution, program, and communities for the betterment of the community. Thank you, and so let's give the floor.
I am a panelist and ስለዚህ የድካም ስሜት አለ። የመጨረሻው ሰዓት እየደረሰ ነው። ግን እዚሁ እያለን ሳንለያይ ስፖርት ያስፈልጋል። በስፖርት ብለን 5 ደቂቃ ደግሞ የምትቀረን ትንሽ አጭር ሚሴስ ትኖረናለች። መቼም ዛሬ ተገናኝተን የበር አከብረን የበር አድምጠን ፓናል ዲስከሽን ተሳትፈን እስከ ኔክስት ደግሞ ምን እንስራ የሚል ነገር ሁላችን እናውቃቸው ነበር ያስባለሁ። ሶ it is the time for physical exercise. With the apology, Mr. Bayo will
Thank you guys. አሪፍ ስፖርት ይመስላል። ጊዜ ያለ ስፖርት ሳይንስ ላይ ያላችሁ ያላችሁ እጃችሁን እንዳታጣምሩት፣ ሁለቱም እናጣምረው፣ ጣቶቻችን እናስተካክል፣ ወደ ላይ እንገልጠው። በደምብ ወደ ላይ ወደ ግራ ወደ ግራ ወደ ግራ ከዛ ወደ ቀኝ ወደ ቀኝ ከዛ ወደፊት ወደፊት በደምብ ወጣን ወደፊት ከዛ ወደ ኋላ ቀስ ብለን እንመጣለን። ወደ ላይ ትንሽ ብድግ 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 ትንሽ እስኪ ሼክ هذا هيك صدق ميك left right what you can push too much
Thank you. በጣም እናመሰግናለን። እዚህ ያስጠለን I think we have one guest. Okay, thank you. The next will be the way forward and any suggestion or comment you may feel. So for that, from Amara Public Health Institute, Director General, and Dr. Jejao will chair this session. So please join. እንግዲህ የሁለቱ ትልቅ ተቋማት ሪፕሬዘንታቲቮች አሉ። ብዙ ሰው እድል አለ። ማክሲመም 3 ሰው ሀሳብ ኤኒ ሰጀሽን 1 3 ሰው ማክሲመም 2 and 3. Thank you.
አማርኛ ነው ማዋራ በእንግሊዝኛ ብዙ አልሰማም፣ ግን ከይም ራስ ተሰራለ በአማርኛ በነገር ይሻላል። በነገራችን ላይ ይሄ ጆይንት ሪሰርች ኢንተርናሽናል አኑዋል ሪሰርች ኮንፈረንስ ከተጀመረ ጀምሮ ብዙ ለውጥ እያመጣና እያደገ ያለ ነገር ነው። ሪሶርስ መጠቀም ነው በዓለማችን ትልቁ ነገር። ሪሶርስ የእውቀት ሪሶርስ ዩኒቨርሲቲዎች ጋር ምክንያቱም እውቀት አላቸው፣ ሪሰርች ተማሪ ያሰራሉ።
ስኪልና ማቴሪያል የትምህርት ተቋማት ላይ በተለይ በጤናው ዘርፍ ዩኒቨርሲቲዎች ካሪኩለማቸውን የሚቀይሩ 5-4-6 ዓመት ሊሆን ይችላል። የጤናው ዘርፍ ግን በየቀኑ እያደገ ዳይናሚክ በመሆኑ ፕሮሲጀሮች፣ ፕሮግራሞች ይቀየራሉ። መሳሪያዎችን፣ መድኃኒቶችን ቀድመው ዩኒቨርሲቲዎች ተማሪዎቻቸውን ከማስተማራቸው በፊት ቀድመው ይደርሳል። ስለዚህ ይህንን ለማገናኘት ሪሶርስ፣ ስኪል እና ኖሌጅ ለማገናኘት በጣም ትልቅ ስራ ነው። እኔ ማድረግ አለበት። ይሄን ብለን ኢቪደንስ ፎር አክሽን ፎር ቤተር ሄልዝ መረጃ ለድርጊት ድርጊት ለመልካም ጤና ትንሽ በአማርኛም ጨመር ብታረጉባት ጥሩ ነው። ወደፊት ይስተካከላል። ነገር ግን ሳይንሱ ተፈልቷል። ብዙ እውቀት አግኝተናል። እውቀት ብቻውን ግን ችግር እስካልፈታ ድረስ ጥቅም የለውም። ለዚህ ነው የዩኒቨርሲቲ ፕሮፌሰሮቻችን ኤንጂኦ ምናምን እየገቡ ነጋዴ የሆኑት። ምክንያቱም ማቴሪያል ሪሶርስ ያስፈልጋቸዋል፣ ሀብት ያስፈልጋቸዋል። ሀብት ማምጣት አለበት። ሀብት ለማምጣት ለምሳሌ ሜንታል ሄልዝ በተለይ በኛ ክልል ባለንበት ሁኔታ ብዙ ሰው ያበደ ነው ይመስል ብዙ ነገር በአራቱ ዲፊኒሽኖች ትናንት በተነገራቸው አንጻር ማንም ጤነኛ ያለ ሜንታል ሄልዝ ላይ ብዙ ነገር ተብሏል። አንጎልና ስነ አእምሮ እንዴት ነው ያለው? አንጎል በምግብ ያድጋል፣ ልክ ነው። ስነ አእምሮ ግን አእምሮ ግን በምግብ አያድግም። ሜንታልና ብሬን የምንለው ማለት ነው። ብሬንን ለማሳደግ ምግብ ያስፈልጋል። ኦፍኮርስ ሜንታልን ለማሳደግ ሳይኮሶሻል ሳፖርት ያስፈልጋል። አንዳንድ ሀብታሞች ልጆቻቸውን ምግብ እየመገቡ የቻይና ዶል ሽጉጥ ጠመንጃ እየገዙ ያስተምራሉ እና በትክክል ወይ ሌሎች ቻይልድ ማለት ነው። ስለዚህ ይህችን የምታጠናክር በተለይ ሜንታል ሄልዝ ላይ ለሰራቸው ሰዎች አዩ ለመምከር አለ። ግን ከብሮቹ ቁም ነገር ስለማይጠፋ አዳም በላይ ብዙ ነገር ሰርቷል። ከሰራቸው ነገር ግን ማድረግ ቀላል አንድ መጽሐፍ አዘጋጅቷል። በምኬት ኢመርጀንሲ ማኔጅመንት ሪፖርት የሚዲዝዝ 20 እንደሆነ ያዘችው እሷ መጽሐፍ በየጤና ጣቢያው ወደ ሱፐርቪዥን ስለወጣ እናገኘታለን። በትክክል አገልግሎት እየሰጠች ያለች እሷ ናት እንጂ ስለሌላው ሳይንስ የተጠቅሰው ምናወራ ምን። ስለዚህ እኛም አንጎልና ሜንታል ወይም ብሬንና ሜንታል ወይም አንጎልና አእምሮ እንዴት ሄደን የሚለውን ማኗል ያስፈልገናል። ለሚቀጥለው ዓመት ይችን ማኗል ስፖንሰር እንደውም እንፈልጋለን። በጋራ ከግሎባል ፈንድ ተዘጋጅታ በአማርኛ በቋንቋ ተተርጉማ ወላጆች ልጆቻቸው እንዴት ያሳድጉ የምትመሳ ትንሽ ፔጅ ያላት ያስፈልገናል። ከትንሹን ጀምር ሩሩሩት አለ። ሁለተኛ ኢመርጂንግ ዲዚዞች አሉ። አሁን አስቦት ዶክተር ተሳሪ አዋኮሊክ እንዳዋኮሊክ አቅርቧል። ግን ይህ በሽታ እንዴት ይወጣል? የሌሊት ወፍ 80 በላይ ኢትዮጵያ ከ80 አይነት በላይ ኢንዶኔዥያ አይነት በተለይ ስራው መሳይነት ያለ አንዱ መቼም የግብፅ ስም ያለበት አይመችም። ፕሮሰስ ኢጂፕቲከስ የተባለው ኢትዮጵያ ውስጥ አለች። አንዱ ፍሩት ተባለ አለች ወይ ባህር ዳር ወዲያ በየክልሉ ጂኦግራፊካል ዲስትሪቢዩሽኗ ቢጠና ለዚህ ነገር ተከታታይ ይፈልጋል። ከዛ በኋላ አፍሪካን ግሪን መንኪ የሚባሉ አሉ። በተለይ አካባቢ ታካለ ሰባሪ ጋር አብሮ ነው የሚመገቡት። በእርግጥ ማለት ቶሎ ስለሚገላቸው ሪዘርቬር ሆት ላይሆኑ ይችላሉ። ነገር ግን ሌላ አርቦቫይረስ አርቦሪያል አኒማል ነው። አርቦቫይረስ ይመጣል። ስለዚህ እንዴት ነው እነሱ መቆጣጠር የምንችል? እስኪ ባህር ላይ ዩኒቨርሲቲ ሰዎች ወደ ከተማ እየመጡ ነው። ባክቴሪያስ ይመጣሉ። እንዴት እንከላከላቸው? ከምናየው ሲምፕል ሩሳሌ ሲምፕል ችግሮችን የምንፈታበት የሚሰጥ በተለይ ለሁለቱ አሳይመንት ለመስጠት ገደላለው። ምንም እንኳን ሰት ሊሆን ይችላል። ስላዳመጣችሁኝ አመሰግናለሁ። በሚቀጥለው ስለተጋበዝኩ አመሰግናለሁ። ደስተኛ ነኝ። ጥናቶች አምናም ተገኝቻለሁ፣ ዘንድሮም ተገኝቻለሁ።
ያየኋቸው ተከታተልኳቸው ጥናቶች በጣም ቆንጆ ናቸው። በሁለቱም የአንድ ጥናት ዓላማው ምንድነው? ችግሮችን መዳሰስ ነው፣ ለቅሶ ማውጣት ነው። ከዳሰሰ በኋላ ደግሞ መፍትሄዎችን ሊሆን ይችላሉ ብሎ ሀሳብ መሰንዘር ነው። እንደዚያ ደግሞ ወደ ተግባር ተረጎሙ የሚያስችል ሁኔታ መፍጠር ነው። ስለዚህ ጥያቄ የሚለው እሺ አምና 57 ባልሳሳት 45 ጽሁፎች ቀርበዋል። ከአምናዎቹ ውስጥ እንደው ችግር በመቅረፍ የሚያክሎቹ ተግባራዊ ሆነው አገልግለዋል። ተጠንተው የሚቀመጡ ከሆነ ጥናቱ ጥሩ ነው የሚሆነው። ግን ዓላማዎች መጨረሻ ያሉት መፍትሄ ሲሰጡ ነው እና በዚህ ደረጃ ላይ የሚታወቅ ካለ የተሰራ ካለ እነዚህ አጥኚዎችም በጣም ይደሰቱበታል፣ ሁሉ ይኮራበታል። ወደፊት የሚጠሩ ጥናቶችን በዛ ዙሪያ ላይ ሊሆኑ እንዲችሉ መንገድ ይከፍታል። እንደ በሚቀጥለው ዓመት በሚደረግ ጥናት ደግሞ ደስ የሚለኝ ቢጠና ብለው እንደው የአማርኛ ቋንቋችንን ወደፊት እንዴት አድርገን እናስቀጥለው፣ ለምርምር ጽሑፍ እንዴት ለምርምር ጥናትስ የሚለውን ቋንቋ አድርገው እየወረደ የት ሊሄድ ነው? በእንግሊዝኛ እያቀረብ አሁን በሀገር አቀፍ ደረጃ ፈተናዎች ውስጥ ነው ያለን። በዓለም አቀፍ ደረጃ የምንፈልገው የምንለው ነገር የአማርኛችን ነገር ምንድን ነው? እንዲያው ጥናት አጥኚዎች በዚህ ዙሪያ ላይ ጥናት ቢጠና ቢደረግ ደስ ይለኛል። አመሰግናለሁ።
እሺ በጣም አመሰግናለሁ። ትናንትና ዛሬ በጣም ጥሩ ነበር። የቀረቡት ጥናታዊ ጽሑፎች ዘርፈ ብዙ ናቸው። በተለያዩ ርዕሰ ጉዳዮች ላይ ያነጣጠሩና በወቅታቸውን የጠበቁ ናቸው። የክልሉን የሀገራችን ኢትዮጵያ ያለንበትን ሁኔታ ከጤና አኳያ ያገናዘቡ ናቸው እና ከእነዚህ ጥናቶች ብዙ እውቀቶችን እና ክህሎቶችን ያገኘን ይመስለኛል። ስለዚህ በቀጣይ መሰራት ያለበት ምንድን ነው? እነዚህ የቀረቡ ጥናታዊ ጽሑፎች በተለይ አብስትራክታቸው ቅድም እንደተገለጸው ተደራሽነታቸውን ማስፋቱ በጣም ተገቢ ነው። በዚሁ ላይ ብቻ ባይገኙ ነው እና በተለያዩ ሴክተሮች እና በተለያዩ ዩኒቨርሲቲዎች ተደራሽነት እንዲኖራቸው ቢያንስ በእንግሊዝኛና በአማርኛ የሚሰራጩበት መንገድ እንዲፈለግ ተብሏል። ጭማቂ ጽሑፎቻቸው ማለት ነው። በተለይ አብስትራክት። ሌላው ነገር ምንድን ነው? የጽሑፍ አንድ የምርምር ግኝት ብቻውን ግባት ሊሆን አይችልም። ስለዚህ ቴዎሪ፣ ሪሰርች እና ፕራክቲስን ሶስቱም አቀናጅቶ መስራት በጣም አስፈላጊ ነው። እንደተገለጸው ከዚህ በፊት ጥናታዊ ጽሑፎች ቀርበዋል፣ ውጤታቸው ቀርበዋል። ነገር ግን ምን ያህል የገጠመን ችግር ለመፍታት ምን ተሰርቷል፣ ምን ያህል አገዥነት አላቸው፣ ለፖሊሲ ለፕራክቲስ እና ለኤጁኬሽን ለመሳሰሉት ነገሮች የሚተገበሩበት ሁኔታ ቢፈጠር ጥሩ ነው። በጣም አመሰግናለሁ።
ተነሱት ላይ እና ቀጣይ ወደዚህ መስራው። ስለዚህ እናንተ ከመናገራችሁ በፊት ያስፈልጋል። ገንቢ ነገሮች ናቸው። ለቀጣይ የምናሻሽልባቸው ነገሮች ስለዚህ ኮመንቶች ወስደው መሻሻል ያለባቸው ናቸው። እነዚህ ነገሮች ሎካል ባሉ የትኛውም አካባቢ አካባቢ በሚመጠበቁ መቀመጥ አለባቸው የሚለው ሄዚቴሽን የለውም። ተወስዶ መስተካከል ያለበት ነገር ነው። እነዚህ ነገሮች አድረስ የሚደረጉ ናቸው። አብስትራክት ሰሚሾች ላይም በዛ ልክ አትሊስት አብስትራክቶቹ አማሪክ ቨርዥን ወይም ደግሞ እንደየአካባቢው ጥናቱ እንደተሰራበት በዛ ልክ እንዲሆን መደረግ አለበት። የምናስተካክለው ነው የሚሆነው ማለት ነው። ከተግባራዊነቱ አንጻር ከአሁን በፊትም በዩኒቨርሲቲዎች ላይ ሴሚናሮች እንደዚህ ኮንፈረንሶች ይቀርባሉ። ዘሴም ነገር እንዲሰራ አይጠበቅም። ያው ላስት ይር ላይ በነበረው ከዩኒቨርሲቲ ፎረሞች ጋር ከዩኒቨርሲቲዎች ጋር የኛ ኤፒኤችኤን በጋራ ሆነን የሳክ የሳይንቲፊክ ስትራቴጂ አድቫይዘሪ ካውንስል ጋር ሆነን የቀረቡትን 56-57 አካባቢ የላቦራቶሪ ባለሙያ ፔፐሮችን እንዴት ነው ወደ ኢምፕሊሜንቴሽን የምንቀይራቸው? ምን ሳይንግ አላቸው? ያ ማለት ፔፐሮች በተለያየ አካባቢ የተሰሩ ሊሆኑ ይችላሉ፣ ግን ኢምፕሊኬሽን አላቸው። ወደ እኛ መጥተን የኢንተርቬንሽን ነገር ዲዛይን አድርጎ ለመስራት የተሞከሩ ሙከራዎች አሉ። ለዚህም የሳክ ሜምበሩን የሳክ ቲሙን ማመስገን እፈልጋለሁ። እነዛ ግን ማለት መነሻ ነው እንጂ የምንወስዳቸው እነዛ ስራዎች በተሰሩበት አካባቢ የራሳቸው የሆነ ትርጉም ተሰጥቷቸው ኢንተርቬንሽን ሊሰራባቸው ስሞል ስተዲ ሊሆን ይችላሉ። ግን እነዛን መነሻ ሀሳብ ተወስዶ እኛም ያለንበት ሴናሪዮ ይወጣል። ለዛም የሆኑ አቴምቶችን በማየት ወደ ስራ የቀየርናቸው ስራዎች አሉ። በጣም ብዙ ባይሆንም የተሞከሩ ስራዎች አሉ ማለት ነው። ግን የተሰጡትን ሀሳቦችም አሁንም የሚቀርቡት ሪሰርቾች፣ ጥናቶች ከመማር ማስተማሩ በተጨማሪ ለኢንተርቬንሽን እንጠቀምባቸው በሚሆን መልኩ እንዲሆኑ ታስቦ ነው የምንሰራው። እሱን በዛ ልክ ለመስራት ዝግጁዎች ነው ማለት ነው እና አቀናይተን ቲዎሪው፣ ፕራክቲስ፣ ምርምሮችን አንድ ላይ ተቀናይተው ለውጥ ሊያመጡ የሚችሉ ነገሮች፣ የህብረተሰብ ችግር ሊቀርፉ የሚችሉ ነገሮች ለመስራት የሪሰርች ቲሙ ከዩኒቨርሲቲ ጋር ሆኖ በዛ ልክ ነው የምንሰራው ማለት ነው። እንደዛ አድርገን እንሰራቸዋል። የተሰጡ ኮሚቴዎች ወስደን የምንሰራባቸው ነው የሚሆን በሚወቁ በኋላ ምናልባት መለስ ሆናል በሌላ ጉዳይ።
አመሰግናለሁ። የተነሱት ነገሮች የሚረዳዋት ናቸው። በዋነኛነት የዛሬው የባለፈው ቢሆን ዓላማ ያደረገው የፕሮግራሙ የማህበረሰብ ችግሮች የሚፈቱ ወደ ተግባር ሊወጡ የሚችሉ የምርምር ውጤቶችን የሚፈልግ እንደ አጠቃላይ ምርምር ሲባል ያው እንደሚታወቀው አንዳንዱ የንድፈ ሀሳብ ቲዎሪ የሚያቀርቡት ሀሳብ ሊሆን ይችላል። ያ ምርምር የሚያደረግ ማለት ይችላል። ከመጡት ምርምሮች ውስጥ ምናልባት አሁን 45 ቀርም ከሆነ ከ45ቱ ወደ ተግባር ሊወጡ የሚችሉ ሊሆኑ ይችላሉ። ማለት ባልሆነ አይደለም። እንደ አጠቃላይ ምርምሮች ግን በሂደት ጎልብተው ነው የሚመጡት። ማለት ለምሳሌ የዛሬ አንድ ምርምር ብሰራ ያ ምርምር እኔ ባለኝ መረጃ በተለይ ልክ ስለሆነ የምሰራው፣ ሌላው ደግሞ ከኔ ሰብሶ ደግሞ በኔ ዘርፍ ላይ ፍላጎት ያለው የተወሰነ ነገር አጎልበት ጨምሮበት ዳብሮ ነው የሚችለው። በአንዴ ወደ ምድር የሚመጣ ነገር ላይኖር ይችላል። ዓላማው በእርግጥ ወደ ምድር የሚወጡ የምርምር ውጤቶችን ያሰበ ቢሆንም አንዳንድ ማስተማር ላይሆን ስለሚችል ማለት ነው። የድሮ አባቶቻችን እናቶቻችን ዜሮንና አንድን የሚጠቀሙበት በቁጥር ደረጃ ነው የሚጠቀሙበት የነበረው። በሂደት ግን እውቀት እየዳበረ መጥቶ ዜሮና አንድ ዛው ዓለምን ሊገለብጥ የሚችል በሙሉ ዓለምን ሊጠቅም የሚችል አስደናቂ ቴክኖሎጂዎች ይመጣሉ። ስለዚህ ዛሬ የተገኙት የምርምር ውጤቶች ነገ ደግሞ ከነገ ወዲያ ደግሞ እጅግ በጣም አስደማሚ ነገሮች ሊመጡበት ይችላሉ። ስለዚህ ዞሮ ዞሮ ምንድን ነው እንደ ኦብጀክት አሳይመንት ነገሻ ያነሱት ጥያቄ አምና ዘንድሮ ደግሞ እንደዚህ አይነት ጥያቄ የሚመጣ ሊሆን ስለሚችል ያ ማለት እንዲህ አይነት ጥያቄ ጠቃሚ ነው። የበለጠ አለፍትበት እንደመሰራ ነው። በእርግጥም ደግሞ የክልላችን ማህበረሰብ አሁን በከፋ ችግር ውስጥ ያለ በመሆኑ ያን ችግር ለመፍታት የቅድሚያ አጀንዳችን ይሄ ነው ስለሚያስብ ከዚህ ውስጥ ወደ ተግባር ሊወጡ የሚችሉ ነገሮችን ትኩረት አድርጎ መስራት በኩል ተመራማሪዎች መጡና በእኛ በኩል ደግሞ የመሰረት ፎረም ሆነ የተቋቋመ ዋና ዓላማው ማህበረሰቡ በእነዚህ አይነት ችግር ነገሮች ሁሉ አቀርቦ መቀጠሉ። ስለዚህ ተመራማሪዎች በተግባር በተግባር በመቀየር ሂደት የምትፈልጉት የማድረግ ወገሳ ሊሆን ከቻለ እኛ ደግሞ ዩኒቨርሲቲዎች በማስፈራራት ወደ ተግባር ሁኔታ ላይ ወደ አጋዥ ይሆናል ለማለት ነው። አመሰግናለሁ።
እኔም አመሰግናለሁ። Thank you very much, everybody. Everybody can say, I mean, those who talk before me, they use Amharic. I know they have a very excellent command of English. Especially Gashagara speak French well, speak English very well, and maybe other language too. But want to make his speech in Amharic. I understand. By the way, when we say international, that doesn't mean Amharic is not an international language or we find not an international language. The thing is, are we communicating with the international community using this language? That's the point. Yeah, we have one very, very specialist from UNOCHA, Jelena. I don't know whether she's listening to Amharic or not. But you listen. By the way, please give them applause. She's very supportive for us. She's from Serbia originally, and she visited Kuala for controlling cholera outbreak. She's always with us, and she's very supportive for the region. And, so for those persons like Delina and other persons who are following this meeting and conferencing, maybe webinar, they have to get the privilege to, listen what we are talking about and what are the very critical issues that we face in this region, so that they can support us and they can, work with us. So please excuse me, I will try in English a little bit, I don't have to in Amharic. Just to reflect my views on some of the questions or comments, I can say comments. This combination of the abstract forms in American English, that's possible. By the way, when we first start this international research conference, as Dr. Zacho said, and there is also a great man with us, we don't honor him, Professor Shikita Agela. The journal, Ethiopian journal, we have the journal of Ethiopian Journal of Translational Science. So, MHI hosted this journal. So, that we make the abstract in Amharic, both in Amharic and English. The details in English, but at least we start. The abstract is in Amharic. This actually is a big task, translating these English languages or, this detailed methodologies, etc. results into Amharic is very difficult, but we are doing that. So, Gashabara mentioned how we are going to make Amharic is a research language. We need to work. There are so many intellectuals. It's possible, I can say. It's possible. Even, the late president of the Bahar University, Dr. Syed
used for academic purpose at the university level into Amharic, and he was raising this question, by the way, Gasha, but I think you were raising the same question. So I think for me it's possible, but it needs commitment, as we do. I'm not boasting, but I think we are making something different. We start joint international research conference, with Bahrain University. Myself, Dr. Zacho, Dr. Professor Shigeta. Then we scale up to jointly with university, Forum of Higher Education Institutions in our region. So it is possible. So I think now others, they started international research conference. So what is the international? We make operational definition for it, by the way. So everybody says international research conference, anyways, that's okay. We started and we will go ahead this conference, and Amharic could be a research language. Yes, it's very possible. We can make it. We are using the research outputs, by the way. APHI, I can say, is now becoming a spice for Amhara region. I can say it can be also for the globe, because we are doing the International Particle Association. And we are gathering many people across the region and even across the country and abroad. So we only focus, by the way, we focus, I can say only focus. Those research outputs has to be changed into action. That's why we gave a name for our journal, Ethiopian Journal of Translational Science. So those research works will be published in our journal. First, they have to be evaluated, and they have to deserve to be published in our journal. They have to first deserve, as they're going to be implemented, or as they're going to be operationalized at the health service level or at the community level. So we are using research outputs. We have, I'm very honored also to recognize Professor Mulgita Kubret, who is with us. He's our chair for Scientific and Strategy Advisory Council. We have 5 subgroups across the region. They are members of the council. So that council will even evaluate, assess, synthesize the research outputs, so that we can, select or identify those who are going to be implemented. And the regional health bureau, as well as the government, can use it for decision making and for planning purpose and for other actions. So yes, we are using research outputs. For Marburg related to the Marburg virus disease, the national government is on activation of the National Operations Center, and they are doing a very excellent job at southern region of Ethiopia. And by the way, they confirmed that this fluid path, the Rosetus Aegypticus, is found in southern Ethiopia. And by the way, I'm afraid that the this virus is not, imported. Yeah, I don't know how it is measured, I don't know, but this fruit bat is confirmed there. There are experts of, bats, so they confirm there, and the industries are, in the indigenous communities who have more air travel history and have no information. Yeah, we need to have, very conscious, and we need to have diversified, experts of, bats or experts of, mosquitoes, different mosquitoes or other vectors. It is time to, academicians, researchers, and the policymakers to, strengthen and rebuild the scientific defense system of the country as well, as well the region. That's what I want to say related to the virus disease. Otherwise, we are also our own, preparation, training of, health workers, orientation, even to the leaders, zonal administrators, and every at the social cluster level, the social cluster lead. She's overseeing and leading the situation. Others are communities. Yeah. So, just to, we are tired, I know we are tired, so we need to finish this international research conference. I want to make some points. I'm not, making this conclusion. It's very difficult. There are very, I can say, very super intellectuals here, extra, those who have extraordinary mind. And what is that the Ethiopian intelligence quotient is very low, as the IQ index posted in the website. You can see the IQ of Ethiopians is very low. I don't agree, because there are many super, intelligent persons in this room. What I'm saying is, I'm not concluding, but just trying to summarize this conference. Otherwise, as I said, there are super intelligent team here who are, writing the proceeding and taking the minutes. Then we will summarize, we evaluate the research. The fourth joint international research conference will be evaluated, and we will write the proceeding, and we will also make a synthesis from it, and we will use it for planning as well as, for decision making. So, since this, I think the core issues that we have to, see forward, or the future directions, that were already said. The first one is enhancing community leadership and co-design mechanisms to ensure the crisis and health programs are resolved. This community leadership is and today also. The community should be, engaged in managing and responding, the crisis. That is a very important thing. So we need to work on that aspect. So one of the core future direction, I think, is this one. So we need to focus on real world research, or this, what we call community-driven research has to be, strengthened. The second one is we need to scale the if there are, actually there are very young researchers, also seniors, there are innovations in different parts of the region or the country. So we need to scale effective intervention using robust implementation research. Yeah, implementation research has to be, has to get focus. Otherwise, in this crisis or this complex, where we go, complicated complex situation, and also in some places there is humanitarian crisis. We need to invest in innovative technologies, like yesterday Professor Mahmoud, he was trying to just give us, from his rich experience, by the way. He's very senior scientist, so he was talking about artificial intelligence, machine learning, etc., and digital health. And he was talking about, using, drones for, IPC wash, IPC, infection prevention measures. So, yeah, if we invest, somebody was trying to mention that Ethiopian investors or Ethiopian, the so-called Balatoch, they have to contribute for innovation. They have to contribute for their people. You see how Trump is getting, affecting the world, and UN agencies are much affected, and other side is vanished. So we need to rely on our capacities. So we need to invest in innovative technologies, digital telemedicine, and we need to access those pocket areas, insecure environments. Otherwise, it's difficult to, make our system resilient. The fourth one is we need to prioritize health system rebuilding and workforce support. Our Vice Bureau Head for the region is with us. Is responsible for workforce development for the region, for regulatory division, and for communicating this. We are lucky he's with us, and so we need to prioritize this, rebuilding the health system. We need to encourage our workforce. Otherwise, we couldn't, particularly this primary health care access. We need to improve the service coverage. The last one, and the very important one, and somebody was joking with me, this became kind of, international mental health conference. It can be because, you can see, this translating research into an action stance. But health systems in crisis affect settings. We are in crisis, we are in complex public health emergencies. So the nurse will all are affected. There's a leadership. Who knows? Nobody has asked. So the fifth point it was discussed is we need to integrate a mental and psychosocial support in our health care service. Not only during public emergency response, but it has to be in our routine health care service delivery. It has to be integrated. We are trying our best, but we can influence. The bureau, our regional health bureau is here listening, so we need to integrate mental health and psychosocial support into the health system. I agree with Professor Vandenbos, without mental health there is no health, he said.
So I agree with that. I talk too much. I think these are, I think some of the points that which leads in our future directions. And as I said, all the details will be summarized inside and we'll use it. And next year we'll see the proceeding. Not only the policy study, we will change it into our action plan. Because APHI Amara Public Institute is one of its responsibilities, making the people of the region actually be safe and well-being and security. So we need to use it for our, we need to incorporate it into our annual plan or 6 months plan, or if there are urgent issues, we need to use it for urgent purpose. That's all I have. Thank you very much.
Thank you. በጣም እናመሰግናለን። ስለዚህ ለዚህ በመጣችሁበት አካሄድ በዚህ በ Thank you. ስለዚህ የታፈሰ ያው የሳይንቲፊክ ቲሙ ኦልሞስት 45 ፕሬዘንቴሽኖች የተመረጡ ዶክተሮች ነበሩ። ከሁለቱ በስተቀር ፕሬዘንት ተደርገዋል። ሁለቶቹ አልመጡም። we did and we'll change it to action. So የሰው ወስጄ ስለሆነ እየሰራ ያለሁት ብሳሳት አስታውቅብኝ፣ ግን አልተሳሳትም። The next session will be ምስጋና ነው። ምስጋና መመሰጋገን ደግሞ ጥሩ ነው። ስለዚህ ትናንትና በአጋጣሚ ማስተር ሰሞኑ በሌለበት ሰዓት የተናገረ ነበር። እንደምታዩት እዚህ ውስጥ አምረን ደምቀን ሁለት ቀን እንቆይ ያደረጉ ብዙ ፓርትነሮች አሉ። እነሱም ደግሞ ዝም ብሎ በእናንተ ፊት ሳናመሰግን መስደድ ተገቢም አይደለም፣ ንፉግነት ነው። ስለዚህ የምስጋና ሰርተፊኬት አለ። የሰርተፊኬት የሚሰጡልን ዳይሬክተር ጀነራላችን በላይና ዶክተር ጀጃው ትመጣላችሁ ማለት ነው። ረኩና ስለዚህ ደረጃ ያለው ግን ምስጋና ነው። ምስጋና ነው። ሁሌም ያው ተቋማቸው ቢሆንም ተቋሙ ተቋሚ ነው ብሎ ይዞ በመደገፍ አብሮ መስራት የዚህን ኮርስ ጃርክ 2025 በትልቁ ድጋፍ በማድረግ እና ፍሮም ኢንሴፕሽን ቱ ዚስ ዴይ ድረስ ያደረገን አማራ ናሽናል ሴት ቢሮ ኦፍ ሄልዝ የምስጋና ምስክር ተዘጋጅቷል። አይ ቲንክ መልካሙ ቅድም እንደተባለው ሁሌም ከጎናችን እዚህ ብቻ አይደለም፣ ከናሽናል እስከ ሎካል ያለምንም ኢቲካል ሳይዝ ወርዶ ማህበረሰብ ላይ የሰጡ የስራ ቤት ማህበረሰቡ ማንም የማይለው ግን ያው ኢቲካል ሆኖ መስማሄድ ስላለበት በኢቲክስ የሚያምን ድርጅት ይህን ብቻ አይደለም፣ ብዙ ስራዎቻችን አብረን ነው የምንሰራው። ዘካተ ሴንተር ኢትዮጵያ እናመሰግናለን። አሁንም ብዙ ስራዎችን አሁንም አብሮ የሚሰራ በተለይም ምርምር ስራዎች ላይ ከዋን ሄልዝ ጋር ኢመርጀንሲ ላይ በጣም ብዙ ስራዎች ናቸው የምንሰራቸው። በማንኛውም ሳፖርት በመተባበር አብሮ መስራት የሚያምን ድርጅት ፕሮጀክት ሆፕ። ታንክ ዩ። እናመሰግናለን። ሌላው በሰፊው አሁንም ተመሳይ አብረውን የሚሰሩ በተለይ የነግሌክት ትሮፒካል ዲዚዝ ላይ አይ ኬር ላይ በጣም እንድንሰራ አብረን እንድንሰራ ሁልጊዜ ጥያቄ የሚጠይቁን ሳፖርታችን ኢትዮጵያ ሌላ በተመሳይ ሁሌም አብሮን የሚሰራ ስራዎች ልክ እንደ ቅድም እንዳልኩ በመተባበር አብረን በመስራት የሚያምን ድርጅት ሜዲክስ ዲያግኖስቲክ ሴንተር። እናመሰግናለን። ከመንገኛው እስከዚህ ድረስ እንደዚህ በሚያምር ሁሉም ሲደመም ነበር። ቨርቹዋል የሚያሉ ሲያደንቁ ነበር። ይህንን ደግሞ በጣም በዚህ ሁኔታ በሙሉ በሙሉ ስፖንሰር ያደረገችን ቲጂ ዲኮር ጊዜ ስለሄደ አስፈላጊ ላይሆን ይችላል። አሁን ደግሞ እናመስግናቸው ነው ባይዘዎች የምናደርገው ነገር ያው ምስጋና ተገቢም ስለሆነ እውነት ለመናገር በምንም ትንሽ ችግር ቢኖርብንም ከሰሚሽን ፔፐር ሰሚሽን ኦልሞስት ኦል ዲጂታል ነበር፣ ስክሪኒንግ ዲጂታል ነበር። ኤቭሪቲንግ ይህን ነገር እንዲሆን ያደረጉት ልጆች ደግሞ ማመስገን ይገባል። በትንሽ የሰው ኃይል ነው የዲጂታላይዜሽን ቤት ውስጥ እየተሰራ ያለው ማለት ነው። ስለዚህ አውትስታንዲንግ ቴክኒካል ሳፖርት ነው የሚለው ፍሮም ኢምፕሊመንቲንግ ኤንድ ማኔጂንግ ኮምፓክት ማኔጅመንት ሲስተም ዩኒሴፍ የሚጠቀሙት ነው። ይህንን እንድንጠቀሙ ያደረገንን ወንድማችን አንዷለም አያሌው በእናንተ ዲጂታል ላይ ደግሞ በጣም የሚገራርሙ ስራዎች ናቸው የሚሰራቸው እና አማይዚንግ ነው። እኔ በጣም ፕራውድ አድርጌያለሁ። በጣም ደስ ብሎኛል። እሱ ጋር ደግሞ አብረው የሚሰሩ ቲሞች አሉ። እህታችን ሄርሜላ ምስጋና one of the outstanding female በጣም እናመሰግናታለን። ስትመጣለች በጣም ብላ ነው። ሌላው አብሮ ሲያግዝ የነበረ ጌትነት ሲሳይ
እናመሰግናለን። ሌላው ቲም መልካሙ ጀንበሩ ስለዚህ ቅድም ዶክተር ግዛቸው ወንድማችንም ስለ ኢፒኤችአይ እና ስለ አሁን ስላለው ጂአርክ 2025 ያው አልፎ ሲያወት ማውራት ቀላል ይመስላል። መመስረቱ ግን ከባድ ነው እና ከባህር ዳር ዩኒቨርሲቲ ጋር ሀገራዊ ያለው ከዛ በኋላ ናሽናል ኢንተርናሽናል ሲደርስ ዝም ብሎ አልደረሰም ነው እንደምታው እና ይህን ደግሞ ያደረጉ ወንድሞቻችንን እናንተ ፊት ብናመሰግናቸው ክፋት አይኖረውም። ራስ ደግሞ ስትሮ የሆነ ስራዎቹም የበለጠ እየበሩ ይሄዳሉ የሚል እሳቤ ስለነበረ ከተወሰኑ ጥሩ አማካሪዎች ዛሬ በእናንተ ፊት ልናመሰግናቸው ወደ ፈቃደኛ ናቸው። ስለዚህ እንዳልኳችሁ ቅድም ደረጃ የሄደው ይሄ የመጀመሪያው ምስጋና መስጠት የፈለግነው ለፕሮፌሰር የሽጌታ ገ ነው። እናመሰግናለን። ሌላው እንግዲህ ከዩኒቨርሲቲ ኦፍ ጎንደር ጀምሮ በመጀመሪያነት የመጀመሪያው ዳይሬክተር ጀነራል ሆኖ የፒኤችአይኤስ የሰራው እዚህ ላይም ይህንን ወደ ኢንተርናሽናል ናሽናል ሲሆን አብሮ ሲሰራ የነበረው ወንድማችን እዚሁ ብናመሰግነው መልካም ነው። ቅድም ወደ ሬሳ ያደረገ ነበር ዶክተር ግዛቸው የለም ወገን እያረባ ላይ ያው ተጠቅሷል። እናመሰግናለን። ሌላው ሁለቷን ዓመት 23 ጃር እዚህ ሲል አብሮን እውነት ለማህበረሰብ በመቆርቆር አብረን እንድንሰራ ጀስት እንደ ጤና ባለሙያ ማለት ነው። እውነት ለመናገሩ ጊዜኛ ከኛ ጋር አብሮ ነው የሚሰራው። የቀድሞ የደብረ ማርቆስ ዩኒቨርሲቲ ፕሬዚዳንት ሴክሬታሪ ጀነራል ፎረም ፎር ሃየር ኤጁኬሽን የነበረውን ወንድማችንን ቅንና ለሰው አሳቢ ኤግዛምፕለሪ ነው ምክሩ ዶክተር ታፈረ መላኩን እናመሰግናለን። በላይ ዶክተር ጀጃው ዘተባያለ በላይ መልካም እናስገር አሁን ደግሞ ለዚህ መመስረት ብቻ ሳይሆን ሁልጊዜ አዳዲስ ነገሮችን ከአካዳሚው ጋር ተቀናይቶ መስራትን፣ ኢመርጀንሲ ላይ መልስ መስጠትን፣ በምርምር ማመንን፣ በኤቪደንስ ላይ የተመሰረተ ውሳኔ እንዲሰጥ ማድረግ እና ከሁሉም ኦርጋናይዜሽን ጋር ተባብሮና አንድ ሆኖ በመስራት ለማጋነን አይደለም። በዛ ልክና እንዲሁም በዛ ልክ ላገልጸው እችላለሁ። ይህንን ኮንፈረንስ ሾርት ፔሪድ ነው። እውነት ለመናገር 6 ወር በፊት ጀምረን መዘጋጀት ብዙ ደራሽ ሌሎች ስራዎች ይኖራሉ። በአካዳሚውም በኢመርጀንሲውም ታውቁታላችሁ። ኢመርጀንሲው አማራ ክልል ላይ ያለው ኢመርጀንሲ ፋታ አይሰጥም። ይህ ሁሉ ተቋቁሞ ቲሙን ኦርጋናይዝ በማድረግ ከውጭም ከውስጥም ያለው ቲም
በሳት ውስጥ ሆኖ መስራት ነው እና ይህን ነገር እንደዛ በሁን የሚያደርገው ወንድማችንን ዳይሬክተር ጀነራላችን ሚስተር በላይ በዛብህ the last but not the least, እንዳለው እንግዲህ በየትኛውም በብዙ ኮንፈረንሶች ላይ ቤስት ፐርፎርመር ያው እንደምታውቁት ሁሉም በየክፍሉ ሴክሬታሪ ሞዴሬተር አለ። ሁለቱም ኢቫሉዌት ያደርጋሉ። ሀገሪ ይወሰዳል። በዛ መሰረት እንግዲህ ኢንዲፔንደንት የሆነ ቲም በጀማ ሆኖ ሲሰራ ነው የቆየው። አሁን ላይ የደረሰው ሪዛልቱ ፎር በዛ መሰረት እንግዲህ ከቀረቡት 43 ውስጥ ከ12 ፖስተር እና ከ33 እና 12 ፖስተር ናቸው። ግን ማንኛውም ፓርት እንደቀረ ሁለት እንደቀረ ነው መረጃ ላይ ኤኒዌይስ ከዛ ውስጥ ቤስት ፖስተር ፕሬዘንተር እዚህ ስኮር ሆኖ መጥቷል። ይህን ሽልማት እንድሰጡልን ነው። እናንተ እንግዲህ ይህ ኮድ ያው ኢንተርናሽናል ኮድ ነው። ከየት እንደመጡ አላውቅም። የመጀመሪያው የፖስተር ቤስት ፖስተር ፕሬዘንተር አበበ ነጋ አዋርድና ደስ ታምቆ ማለት ነው። ይከፈት እያሉ የሰላም ተረዳቢ ማለት ስለዚህ አበበ ነጋ on behalf of AFI and organizing committee for joining the JIARC 2025, we are pleased to inform you that you have been selected as one of the award recipients for your outstanding scientific contribution. This letter serves as an official confirmation that you will receive a monetary award of 10,000 Ethiopian birr in recognition of your as the best presenter, uptake and proficient preference of differentiation service delivery model for HIV treatment in sub-Saharan Africa. Thank you so much. Best oral. Best oral really deserves. Thank you so much, Mr. Tayezo. እናመሰግናለን። ታየ ታውቃላችሁ። ታየ ያው የባህር ዳር ዩኒቨርሲቲ የሶስተኛ ዲግሪ ተማሪ ነው። ፐብሊኬሽን ኦልሞስት ድል ነው። ዲዘርቴሽን ራይት አፕ ላይ ነው። ዊዝ ዚስ ኮሚትመንት ሂ አክት አስ ፉል ታይም ወርከር ነው። አክት ያደረገው ፒኤችዲ የተማረ ፉል ታይም ወርከር ነው። እውነት ነገር በቋሚ ሰራተኛ ሆኖ የሚሰሩ ብዙዎች ነገር ኤንድ ፎር ኤኒ ክፍተቶችን የሚሞላ ልጅ ነው። ቬሪ ኮሚትድ ልጅ ነው። ስም መሆኑን ገርሞኛል። On behalf of API and organizing committee, we are pleased to inform you that you have been selected as one of the awardees for your outstanding science contribution. This letter serves as official confirmation that you will receive a monetary award of 10,000 Ethiopian birr in recognition of your achievements as the best oral presenter, diagnostic performance of biomedical, biome, and LAMP with about real-time PCR as a gold standard for our media consulting. Thanks so much. በጣም እናመሰግናለን። አብሮት አብሮት ላይ ያሉ ወንድሞቻችን ለሲነጋ ነው ዶክተር የነው ልጅ ትምህርት ማጥናት ስለነበረበት ነው ዶክተር ዛሬም ያጣደቀንትን ስለነበረ ዶክተር ዲክሰኝ በተመሳሳይ እንደዛው ትናንትና የነበሩትን ፕሮፌሰር ማሞ ለማስተማር ለመስጠት ዛሬ ኮሚቴ ነበሩነት በአይኖሩም በሌሉበት ማመስገን ጥሩ ስለሆነ ማመስገን ፈልጋለሁ። አመስግኑልኝ። እዚህ የዘንድሮ ቲም ደግሞ የተለየ ሆነ ጀስት ታይምሊ እንዳይሰለች ታይምሊ በመገኘታችሁ እናንተ እግዚአብሔር ያክብርልኝ፣ እግዚአብሔር ይስጥልኝ እናንተ። ስለዚህ ኦፊሻሊ እንደተከፈተው ኦፊሻሊ ደግሞ መዘጋት ስላለበት ዛሬ ኦፊሻሊ ወደ ሰው ወደ መጣበት በሰላም ይገባ እንዳይሄድ ዘንድ ኦፊሻሊ ይዘጋል።
Thank you very much. አሁን በአማርኛ የምናገረው በጣም አመሰግናለሁ። ሁላችሁም እስካሁን በጣም አድካሚ ቀን ነው ዛሬ ብዙ ስራ ስለተሰራ አሁን አላስረዝምም፣ ማመስገን ነው። ወደ የመጣችው አንተን ያው በአይዶን ወይዘር ቲካል ሆኖት እኔ እንትን አላልኩም የለሁበት። እንደዛ ከሆነ ማይ ቲም is there to realize this. በጣም ምክትልና ዳይሬክተሩ አሉ ፎረም ፎር ሃየር ኤጁኬሽን ኢንስቲትዩሽንስ ቲም አለ። እዚህ ያሉት ማለት ራሱ ዶክተር አዳል ሌት ተቀን 6 ወር ጀምሮ ስንሰራ ነበር። በጣም ከባድ ስራ ነበር እውነት ለመናገር። ከኮሚቴው ጋር ሌላ ኢቨንት እኔም በዛ ቢሆን ኖሮ ሶስት ቦርድ በእናንተ በፊት በእናንተ ፊት ይቅርታ አለባቸው ወይም ይቅርታ ይደረግላቸው አትገልጹልኝም? አስፈቅዱን ስለሸለሙ የሚለው ትክክል ስለሆነ እንግዲህ ቅድም ያልኩት ነው ማጠቃለያ ወደፊት ተቀርቧል። አክኖሌጅመንት በደንብ ተደርጓል። ግን በድጋሚ ብንል ጥሩ ነው። ይህንን መጀመሪያ የአብቅና የህብረተሰብ ጤና ኢንስቲትዩት ህጋዊ ስም የአብቅና የህብረተሰብ ጤና የአማራ ብሔራዊ ክልላዊ መንግስት የህብረተሰብ ጤና ኢንስቲትዩት አማራ ፐብሊክ ሄልዝ ኢንስቲትዩት ኤፒኤችአይ ለማሳጠር ጊዜ ነው ነው ይህ ህጋዊ ስሙ ነው። ይህንን ተቋም በማቋቋም ከኢትዮጵያ ፐብሊክ ሄልዝ ኢንስቲትዩት ሁለተኛው ነው ከብሔራዊ ቀጥሎ የተቋቋመው ይህ ተቋም ነውና ይህን ተቋም ላቋቋመው የክልሉ መንግስት ምስጋና ብታቀርቡ ደስ ይላል። ምክንያቱም የክልሉ መንግስት የተቋም እንዳይቋቋም በዚህ አይነት መንገድ ምናልባት ሊገናኝ ይችላል የሚለውን ስለሆነ አሁንም በትናንቱ ዌልካም ስፒች ላይ እንደገለጽኩት በጣም ስትራቴጂክ ፒላሮችን አውጥቶ ዝርዝር ማንዴቶቹን እንደገና በደንብ ያየ ዓለም አቀፍ ስታንዳርድን
ነው ሲዲሲ በሉት ሄልዝ ሴኩሪቲ ኤጀንሲ ዩኬ በሉት ኢትዮጵያ ፐብሊክ ሄልዝ ሲዲሲ አፍሪካ ናይጄሪያ ሲዲሲ ኤኒዌይስ ሲዲሲ ፐብሊክ ሄልዝ ሄልዝ ሴኩሪቲ ሶስት ስሞች ቢሆኑ ተግባራቸው አንድ ነው። የኛም የህብረተሰብ ጤና ኢንስቲትዩት እንዲጠነከር ማለትም ሪቫይዝ እያደረገ ስለሆነ በደንብ ክሊር የሆነ ማንዴት ሮልስ ተሰጥቶት እነዚህ በጣም የኛን ሞቲቬሽን እንድንሰራ በደንብ ስላደረጉ የክልሉ መንግስት የክልሉ ጤና ቢሮ ኦፍኮርስ በተለይ ደግሞ ማህበራዊ ክለስተር በጣም እንደው በድጋሚ ተመሰግኑልኝ። የኢትዮጵያ ፐብሊክ ሄልዝ ኢንስቲትዩት ይህን ያልኩ ለምንድን ነው እንደ አሁኑ የኢትዮጵያ ሄልዝ ስትራክቸር እውነት ለመናገር እኛ ቀይረናል እያለ ነው። በዚህ ወንድሜ ገነቱ አለ ነባሮቹ አቶ ሸገዋሉ ሲቋቋም ይሄ አሁን we have the Tigray Public Health Institute, we have the Afar Public Health Institute, Sidama Public Health Institute, Central Ethiopia, South Ethiopia, South West Ethiopia. ወደ 8 ሪጂናል ፐብሊክ ሄልዝ ኢንስቲትዩቶች መጥተዋልና ይሄ አማራ ኮንትሪቢዩት እያደረገ ነው ለቪዥን ኦሮሚያን ትልቅ ግንባታቸውን ምርት እያደረጉ ነው። ክልል መንግስት ስለጸደቀ ደግሞ ሪኮግናይዝ ማድረጉ ተገቢ ነው። ምክንያቱም ቅድም እንደተጠቀሰው ሄልዝ ሴኩሪቲ ላይ መጣችሁ አለሞቻችሁ በሁሉ ላለፉት 5 ዓመታት በየሳምንቱ ሁልጊዜ ኢንሲደንት ማኔጅመንት ሚቲንግ እዛ ላይ በየሳምንቱ 233 ሳምንት በላይ በየሳምንቱ ከተለያዩ ኤጀንሲስ የተለያዩ ጤና ቢሮ ዘርፎች ኤንጂኦስ በዛ መንገድ ነው ኮንቲኒየስ የሆነ ስራ እየሰራ ያለውና ሪዚሊየንስ ዝም ብሎ ቢውልድ አይደረግም። እንደዚህ አይነት ሲስተም መኖር አለበት። ይህን እንድናደርግ ስላደረገ ምስጋና ሁሉ የጠየቋችሁ ኤጀንሲስ ኤንጂኦስ ቅድም የተሸለሙ ተቋሞች ዩኒቨርሲቲዎቻችን አብረው ቅድም እንደተባለው ነው ራንክ ኦፍ ፕሮፌሰርሽፕ ዋቴቨር many degrees but listen to us without raising that ego. They are working with us, Professor Dr. Baye, Dr. Awaris from Shoa, Dr. Dasani came from Harvard University. Please applaud for him. በጣም የስማችሁን ያጠቀሷችሁ ብዙ ሰዎች ይኖራላችሁ። በጣም አመሰግናለሁ። ጋሻ በረ is very senior but he was always with us. ዶክተር ጃጃው ዶክተር ታፈረ ዶክተር አበበ ግርማ ቼር ፎር ሃይር ኤዱኬሽን ኢንስቲትዩሽን አማራ ሪጅን ፓናሊስትስ ሌሎቻችሁ አብሮ ያሉት በነገራችን ላይ የፕሮፌሰር ማሞሙጬ በጣም አጭር ጊዜ ምን ሁሉት ወይ ምናምን ብዬ ነው የጠየኳቸውና ሰፖርት አስ ጀስት ኮንትሪቢዩት ሰምቲንግ ፎር አስ እና እዛ ሆኖ አይታችኋል ቢሯቸው ውስጥ ሆኖ ምናምን በጣም ብዙ ነገር የሰጡን ነገር በጣም ሰፊ ነገር እንደሆነ ፓወርፖይንታቸውን እንደገና ማየት ይቻላል። በጣም ብዙ ልምድ ያላቸው እሳቸውን በሌሉበት ቢሆን አመስግኑ። በጣም አመስግኑልኝ። ሳይንቲፊክ አድቫይዘሪ ካውንስል ሜምበርስ ኦል እነሱን እንድታመሰግኑ አብሮን ሁላችሁም አንድ የራሳችሁ በጣም አመሰግናለሁ። So I declare that the 4th Joint International Annual Search Conference JIARC 2025 is officially closed. Thank you.
በጣም እናመሰግናለን እግዚአብሔር ይስጥልን።
Can we have all these presentations from this conference